Good morning, everybody, and can I welcome you all to the July meeting of our board held in public. As ever, members of the public are very welcome here. We are live streamed today, and the recording of the meeting is going to be on the Trust YouTube channel. We've also got, as I think we all know now, the live subtitles, which can be accessed by clicking on your screens. If I could also take the opportunity to welcome Adrian Davis, who is our new non-exec director. He did join us a little while ago, but this is the first time you're joining us in our meeting in public, Adrian, so you're very welcome. Just our usual etiquette, mic muted if we're not speaking. People introducing reports can assume that they have been read and give us key points only, not going through the whole report. We'll ask questions once the speaker has finished. We will go on trying to avoid the use of acronyms, but if we don't, please could anyone catch us out and help correct us. We are all online today, but for those of you who are in the building, there are no fire alarms planned. Any questions members of the public have, please could you raise in the Q&A function, and they'll be reviewed by our company secretary, and they will be raised at item 17, and our company secretary will ask the questions on your own behalf. We're hoping to conclude around about 2 o'clock today, and we'll have a half-hour lunch break, approximately 5 to 12, just after item 9. I don't have apologies today from members of the board, but I do have apologies from Usma Bazai, our next director, who is usually in attendance. Could I check, please, whether we have any declarations of interest? No, thank you very much. Bringing us then to the minutes of the previous board meeting, I would like us to review and approve these minutes of the meeting held on the 2nd of May. Are there any queries or matters to material? I don't think so. I'm seeing shaking heads. Ian.
Yeah, just a minor one that I'd spotted, Myra. So on page 17 of our packs, and then again on page 18 of our packs, it quotes the historical deficit that was written off for the ICB as 115k, but it should be 115 million. Elsewhere in the report, it quotes 115 million in the minutes. So it's just to make sure those two items are corrected to record what is a significant difference between 115,000 and 115 million.
Oh, I'm glad you're on our board, Ian. Thank you for checking. That's lovely. We'll correct that. Alistair.
Apologies, mine's much more minor than that. It's on page 11, section 10.2, learning from death, paper A4, other liver disease, an interesting group, and not alcohol and cirrhosis. That should be not sclerosis. It's just a minor typo. Thanks.
No, that's very helpful, Alistair. Thank you. Do people have any other matters to raise? In which case, I would like you just to give your approval to the minutes in the chat, and then can we come to the matters arising? There are really good notes on the log. Are there any questions on those updates? If not, then can we agree those actions proposed as complete? And if you would just do that in the chat for me, that's helpful, thank you. And then I'll come to Kim O'Keefe, our Chief Nursing Officer, to introduce our patient story, which is today on the volunteer service. Kim.
Thank you very much, Chair, and I'd like to welcome Verity Barker, who's with us today, who leads, supports and guides our wonderful group of volunteers, and she'll be here today to be able to answer any questions. So firstly, can I just remind us all and to give a big shout out and a thank you to all the volunteers who give the gift of their time that both supports patients, supports each other, supports our staff, and works collectively as an integral part of our workforce. They are full partners, and we fully recognise that. We have 264 volunteers currently. We have another 21 applicants we're looking at to recruit, and 12 applicants we're awaiting to interview. As you can see when we see the video, we've got over 25 volunteer roles, and they are varied, vast, and span not just our ward bases, but many other of our outpatient services and others. Their roles range from befriending, patient experience, butterfly companions, activities, part of our ward accreditation peer review teams, refreshments, admin control, coffee shops, and many, many more. And as Pete will well know, they're part of the Community Hospital Broadcasting Network. It was recently our Volunteer Appreciation Week, and thank you to everyone who worked alongside our volunteers. And just to remind, if anyone didn't have an opportunity, we don't have to do that just in Volunteers Week. Verity and the team would, and any of our volunteers would be happy to see you as they go about their business. We've got new roles and development. Those include carer support work, volunteer role, volunteer to career, dementia activities with a mobile trolley, reception support in the bereavement office, and we're looking at reintroducing the outpatient refreshment service at West Cornwall. So with that in mind, Peter, if we could play the video, please.
Betty, what would you say is your reason for volunteering here at Royal Cornwall Hospitals?
Well, I like to help anybody if I can. I've tried over the years. I've done a lot of singing, local singing.
Yeah.
I still sing with 3 different choirs. But yes, if you can make somebody happy and feel relaxed, I think this voluntary work is wonderful for me at my age, yeah.
Well, it's at the end of COVID. I wanted something to do. And I looked to have a job here, but it was obviously you'd have to work set hours, and I didn't want to do that. So then someone recommended volunteering. Never heard of it.
Yeah.
So I took it on board, and here I am 2 years later. I used to work at Land's End Airport.
Oh, did you?
Yeah, I used to call myself aviation security.
Yeah.
Better known to you and me as a check-in agent.
My name is Millie and I'm 19 years old and I live in Lanna and I've come here to volunteer, come here to volunteer because I love helping people out and I love making people smile.
Sitting with the patients and just holding their hands, just being there and being there for the families as well.
I'm working in the Health and Safety Department right now.
Brilliant. And what made you want to come over to Health and Safety to volunteer?
Yeah, to improve my communication skills, to be more confident and to be around people.
Over a period of 10 years, I lost 2 brothers and a sister, and the hospital were brilliant, looking after them. So that's why I decided to do it, to put it back in.
You have a number of volunteers here on the ward. What does it mean to you to have volunteers here with the patients?
Like I was saying to you a minute ago, it's completely integral to our unit actually, isn't it?
Yeah.
They, keep the patients really comfortable through the day. So often the first questions patients will say when we have their pre-assessment is, can I bring my own food in, or is there going to be food there? They're worried about sort of hydration and food for the day, and then are really sort of happy when they get here that they have that provided all day to them.
And they're just amazing. They're a listening ear. They're just somebody else to talk to that isn't a health professional, that the patients just love.
And the patients make a rapport with all of them, so they get to know them as well, because they're back each week with the same volunteers. So it's part of the unit completely.
I bring Aggie to the hospital about once a week, and she visits patients. She'll sit on beds and get cuddles, or she'll sit on laps and get cuddles. She loves it, and I love it.
It's lovely having volunteers here. It gives people a real lift, it gives people a real boost. There's a lot of patients that are in for extended amounts of time, all have pets, and it's nice to have somebody coming in like little Aggie, cheers everybody up, gives them a taste of home, it really comforts some people. It's lovely.
Thank you. And as you can see, it wouldn't have been a video without Aggie either, I have to say. She's a very popular member of the team. But for the eagle-eyed amongst you, we'll also see some of our previous colleagues who are now in the volunteers and still donating their time. Verity, is there anything you'd like to add before I open up to questions?
No, I'd just like to say thank you to our board for all your support. It was fantastic to welcome so many of you during Volunteer Week to celebrate the first birthday of our wonderful Butterfly Companion volunteers. And we do so appreciate the support that you all give to our incredible band of volunteers. Our volunteers give the gift of time to the hospital. And it's so important for our patients, for our patient visitors, for our members of staff, and for volunteers that volunteer alongside them, that we're able to provide this, as Mari has identified, integral service to support our patients. And we continue to want to develop, and just to say thank you again for all that you do to support us. Thank you.
Thank you, Chair. I shall hand back to you for questions.
Thank you, both of you. Thanks, Kieran. Thanks, Verity. It's just fantastic. What a wonderful film that is. And just, you say they give us the gift of time. They do. They give us the gift of smiles as well, don't they? And really hard work in all sorts of places. And it was lovely to hear what a range of different people we've got in those volunteer roles. Absolutely super. So credit to everybody who does the recruitment and the support to our volunteers as well. So thank you. Colleagues, do you have any questions for Verity or Kim? Isabel.
It was a comment, really. I mean, fantastic film, and my eyes just strayed occasionally away from the film to see the broadest of smiles on Verity's face watching that film. And I think that it was really lovely to see that, you know, how engaged you are and how appreciative you are of the volunteers that you're working with. So I just wanted to comment on that, and thank you very much for all that you're doing, Verity.
Thank you, that's very much appreciated. We'll pass it on to the rest of the team, because we're very much a team here.
Thank you, Isabel. Please, Pete, could you take the screen down? That's right, because I can't see people. So I've got Richard first, please. Richard S.
Okay, and thank you so much. Thanks for this film and the presentation of Verity. And I've had the chance over the last few years to meet a number of our volunteers, and what an amazing set of people they are. It isn't just the gift of time, it's the gift of care, compassion, all of the skills and diversity they bring. My question to you, Verity, is really, what do you see as the next future directions for volunteering, and how can the board help and support you?
Thank you for that question, Richard. I do appreciate it. We are going to ask for the inevitable support, which is in the area of funding. Like funding to support our going home bags, that's our discharge project, whereby we provide bags of basic groceries to frail, vulnerable and elderly patients, and to enable them to have food and drink for the first 24 hours post-discharge. They then get a "Hello, how are you" telephone call from one of our volunteers. That is then recorded on the IQVIA system, so the wards can see what feedback has been received. And additionally, thanks to support from the Inclusion Matters Hospital Discharge Officer, our volunteers can then refer patients to that team, and they can actually provide practical support, gardening, shopping, befriending, and most importantly, help with social services referrals. We have had some funding for this. Most recently, £800 from Smile Publishing, who published our volunteer booklet, which was most welcome and a very generous donation. Prior to that, Cornwall Rural Community Council have given us funding for 100 bags, and SD Solutions via RCHT charity, who were so supportive of everything we do, gave us another 50 bags. It costs approximately $4,750 annually for our going home bags. And the feedback we get is amazing, because obviously it's given as a gift to patients, and then we can then follow through their recent discharge. We've spoken too quickly. And we would also like to look at funding to enable us to extend the hours and reach of the Butterfly Companion Volunteer Initiative. And that is approximately £5,000 annually. With regard to going forward, as we have said, our roles in development, the carer support volunteer role, we are actively looking at how we can actually identify carers when they're in the hospital, and therefore we can then offer the support. And we are very keen to engage with the National Volunteer to Career Initiative, supporting those that come to us as volunteers and then move into a job. You saw Sawande on the video, our volunteer who's supporting health and safety. She's only 17 and she's going to be moving on to an apprenticeship with us. We've had a number of volunteers who have moved into a career with the Trust, and it's so rewarding when you see those of all ages, from a gentleman who was well over 25, who's now a healthcare assistant, to another 18-year-old who has an apprenticeship with the theatres team. It's a very rewarding job that we do. So again, what I would like to say as well is just thank you to all our volunteers for the difference they make. And that's me.
Verity, I've got a few other people wanting to come in.
Yeah.
So no, not at all. We'll pause there. I've got Ella, and then I'll bring Ian in, and I'll ask Ian to address the issue of funding. But let's, I think, Ella, you're next, although I seem to have lost you.
Thank you. Yeah, so my question was actually going to be very similar to Richard's, but Verity, having heard your answer, I suppose I'd just extend an offer of support to your team. So I'd see this work very much as a partnership, and that's something that sits in my portfolio as well. So if there's any of those developments that you would like some support with beyond today, it would be really great to speak with you, because one of the things as we were watching that video that struck me was actually it's quite innovative, some of the roles you have, and clearly it would be great to support you in taking those further and faster. So yes, just an offer really.
And can we just say, Ella, we remember you in the coffee shop a few years ago when you supported volunteers.
I hope I didn't spill anything.
Thank you. Thanks, Ella. Ian, if you'd be so kind as to make your comment, but also pick up the comment about charitable funds.
Yeah, I might do it the other way around. So thank you, Verity. And I really enjoyed my stint volunteer week with the patient experience team and seeing the amazing work that they do. So thank you for that. So in terms of charitable funding, I think that's the volunteer network and the sort of schemes you've talked about there are absolutely perfectly placed in terms of our charitable fund and as a trust that we have, and we're very fortunate that we have significant donations from generous members of the public, staff and others, that communities that raise funds for our charity. So I've asked my charitable funds accountant to contact you and just help you through the process of making those applications. My comment or observation was, hopefully there's some members of the public and members of staff that are watching this. I just wondered, how do people go about registering their interest to volunteer or making that initial connection if they're interested?
Well, the initial connection is through the Trust website. We have an online application form, and you'll then be invited along to a very informal group interview, or we're happy to discuss the volunteer roles with you individually. There is then a slightly formalised recruitment process in that we have to do a DBS check as appropriate, occupational health check, and we do ask for 2 references. To explain to members of the public and anybody else who's listening, this has been as a result of the Lampard review report. The Lampard report, which came out following the Jimmy Savile situation, whereby he, as a volunteer, abused his trust. And so we want to ensure that we recruit volunteers safely for both their safety and for the safety of the trust.
Thank you, Verity. That's really helpful. Thanks for that question. I've got Richard Kay and then Steve.
Yeah, hi, Verity. As with the others, a really wonderful video to see. What my observation is that just looking at the faces of the volunteers is that volunteering isn't a one-way street. It really helps improve the health and well-being of volunteers. It helps communication skills and actually encourages, and it's great to hear that, how volunteers can move to paid roles. So I just wanted to ask about support to volunteers once they've started. How do we look at volunteer satisfaction, and how do we ensure the feedback of volunteers are taken into account?
That's an excellent question, Richard. We'd had our first volunteer questionnaire survey prior to us developing our new strategy, which is coming to you later, and that was a great value. Additionally, during Volunteer Week, we had a couple of volunteer forums. Again, as a result of our strategy, we wanted to ensure we engaged more. We had a volunteer forum down at West Cornwall, where obviously we've got a fantastic cohort of volunteers, and we had another volunteer forum here at RCH, and it brought back to you why people volunteered. The key to the forum was actually sitting in a room with a diverse group of volunteers, with them sharing their experiences and what an effect that those experiences has had on patients and on them. And it was actually quite humbling, because it's easy to forget in the rush of meetings and reports, etc., that the basis of all of this is that act of human kindness. And that's what volunteering is all about. So we do engage very much with our volunteers. And I know when Aoife Kavanagh came round with me, we undertake to know our volunteers personally as well. We help and support them on a personal and obviously on a professional level.
Thank you very much, Verity. Steve.
Yeah, thank you, Verity. My questions have actually just been asked by Ian and Richard. So just a comment. I had the chance to spend a little bit of time with volunteers at the Cove Cafe with our butterfly companions and in community radio over the last couple of weeks. And I was amazed and inspired by everybody I met. So I just wanted to say thank you to all of our volunteers. You talked about the gift of time that they give. It is incredible. And the impact that that gift of time has is amazing, not just on our patients, but on our staff as well. So thank you to every one of our volunteers, and thank you to you for your leadership as well in terms of supporting them.
Thank you very much, Steve. I hope what you've seen, Verity, with the interest and with the questions, how very much we do appreciate what you and your team and all of our volunteers do. It's absolutely amazing. And I'd go so far as to say patients would not get such a good deal if we didn't have our volunteers. So they really are part of this team, and we're very, very grateful for everything that's done, and particularly to you and your team for organising it, because it's not always easy to organise volunteers. But
it's not always
really
fluffy.
No, it isn't. No, indeed not. So can I thank you for helping us to have a really good start to our board. You brought a smile to everybody's face, and thank you very much for all the work that's done in our trust.
Thank you.
As I always say to visitors, Verity, as it's a public meeting, you're very welcome to stay, but I suspect you've got more to do with your time.
We are quite a busy morning, but I'd like to say thank you to Kim for introducing our items. Thank you. We worked with Kim for a long time, and we really do appreciate your support. Thank you all. Bye.
Bye. Thanks, Kim. Great start to our day. Thank you very much. Feels very boring to come to my report after that, but there it is. You have it in front of you. There's a couple of things I just want to say about it. One is that I want to just correct an inaccuracy under the Remuneration and Appointments Committee. We do not include the Chair of Audit and Risk. So Adam is not a member of that committee. My apologies for that. The only other thing I would say is that thank you very much to Richard Kramer, for taking over the chair of charitable funds in the interim. Both Richard and Adrian are just on their induction tour of all the committees, and we haven't quite settled on who will be going where, but I'm very grateful to you, Richard, for chairing that in the interim. I'm very happy to answer any questions on the report. if anyone has any. Okay, in which case we are asked to note the report, and also if we could endorse Richard Cramer and Adrian Davis joining the Remuneration and Appointments Committee. That would be great. Again, if you would just note and approve in the chat. Alison, before I move on to Steve's Chief Exec's report, I apologise, I didn't see your hand under one of the action log items. Would you just like to raise that now?
Yes, one of the actions we can't complete until we write the new annual reports on education, clinical and non-clinical, and I was wondering whether we could include that action within the work plan rather than keep it on our action log for the next year.
Thank you. Lindsay, are you able to advise on that? I think we may have lost.
Sorry, Mary, I missed the comment.
I just wonder if you could advise on Alison's proposal that we, well, Alison, say it again.
Yes, sorry, Lindsay. I was wondering, rather than keep sort of something on an action log, which we can't close off for almost a year, whether we could include it in the work plan, so we don't lose it as an item, rather than keep saying, well, we can't close this item off yet because it's not due to be reported. Thank you.
Yeah, I'm very happy to do that, Mary. That's a helpful suggestion. We can add it into the work plan, note in the action log that that's going to be the case, and obviously that can then be monitored with a note within the work plan as well. So I'm very happy to, if board colleagues are happy to proceed with that request, very happy to action that. Thank you.
Great, thank you very much, Alison. Then bringing us to item 7, Chief Executive's report. Steve, any comments you would like to add to your report?
Yeah, just a couple if that's okay. So I'll take the paper as read, but if I can just draw board's attention to a couple of matters that are within the paper. First one is the provider licence. As you'll see in the report, NHS trusts have been required since 2023 to hold a provider licence and to undertake an annual self-assessment against that. So Appendix 1 provides the updated self-assessment covering continuity of services and availability of resources, and we are asking board to approve that submission. So that's one item to draw board's attention to. You'll see we've provided an update on the governance improvement plan as well, showing progress against the plan for last year and outlining the areas of focus that will be used to inform this year's governance improvement plan, and we'll bring that forward to a future board meeting for approval as well. I should reflect, as it's said in the board, that we did have an IT network outage issue on the 11th of June, where for local network reasons we lost access to almost all of our IT network temporarily. That issue was rectified later that day, and most systems were re-established that afternoon or that evening, with final systems being re-established the following morning. As you see in the board paper, though, it did have a significant impact. All parts of our organisation immediately mobilised their business continuity plans, and they were effective. Nevertheless, we did have impact, and you'll see that a number of outpatient appointments were required to be postponed and rescheduled, and that was the case for some inpatient surgeries and procedures as well. So there's a report within the Chief Exec's report that identifies that. I want to say a little bit more about performance segmentation. That's in the report, but just particularly mindful of members of the public who might be watching this meeting. The NHS Oversight Framework identifies four segments: Segment 1, Segment 2, Segment 3 and Segment 4. And provider trusts and integrated care systems are assessed in one of those segments, with Segment 1 being highest performance and Segment 4 being some form of national oversight and intervention. And as you see in the report, our latest review maintains Royal Cornwall Hospital's NHS Trust in Segmentation 3, and that's also the case for our integrated care system as well, who remain in Segmentation 3. Two other things to briefly update on. Firstly is urgent and emergency care performance. So two components to this. Firstly, the report refers to a letter that all NHS Trust boards and integrated care boards received from NHS England, setting out absolute clarity on the requirements for all NHS Trust and system boards to main focus and oversight on quality of care and experience in pressurised services. To an extent, that letter follows the Dispatches documentary on Channel 4 last week about the Shrewsbury Hospital emergency department experience, and sets out requirements for boards to ensure that as much as possible systems and organisations support alternatives to ED, so only those patients who need to come to an emergency department do so with alternative opportunities provided elsewhere in the community, and also requires boards under times of exceptional pressure to ensure that there's appropriate oversight of patient flow escalation areas and spaces. So quite a lot of details provided in the board report around that, including links to the National Urgent Emergency Care Recovery Plan as well. The second part of urgent and emergency care to mention is we've been under increased pressure recently due to a number of reasons. They include that we have seen a deterioration in our no criteria to reside patients who are awaiting some form of onward care. We had seen some significant improvements in that, particularly through the month of April. However, that has deteriorated over the past 6 weeks or so. And in addition, we've seen a reduction in inpatient capacity in other parts of our health and care system, where due to some building risks, the bed capacity available at Bodmin Hospital, which is operated by Cornwall Partnerships NHS Foundation Trust, has had to be temporarily reduced whilst urgent action is taken there. So both of those aspects, the increase in no criteria to reside patients and the reduction temporarily in some of the community capacity, have had an impact and implication on all parts of our urgent and emergency care system, but particularly within Royal Cornwall hospitals as well. And then finally, just to draw board's attention to the Martha's rule update, delighted to see that Royal Cornwall Hospitals NHS Trust is one of the first in the country to be part of the rollout of Martha's rule, and we had been involved in that prior to that national update, but really positive to see that. So happy to take any questions on any parts of the report, Mary.
Thank you very much indeed, Steve, and really good news about us being one of the first cohort on Martha's Rule. That's a great thing. Colleagues, are there questions for Steve today? Alison.
Not a question, but just wanted to pick out from Steve's report something to celebrate, which was Beth and Andrew being shortlisted for Rising Star, and the adultery nurse team as well. 2 awards there, one for Caroline Ellis and one for the team regarding outreach. I just wanted to say well done. Thank you.
Yeah, absolutely well done, and what a lovely picture it was of them at the awards ceremony. So really lovely. Richard S and then Richard K.
That's fine. Alison's covered that. I just wanted to draw attention to those news items at the end of the report, which are really good to see. Thank you.
Thanks, Richard. Richard.
Yeah, I just wanted to ask a couple of questions. One was on patient flow and social care, and the other one was on changing places, which is a great thing. Small item, but I wanted to elevate it if that was all right. Just on social care, and just in terms of emergency care access standards and in terms of data, do we quantify, and I may have got this wrong, the amount and measure the trends in which a lack of social care provision takes part for the responsibility for delaying discharge? And can we just say a little bit more how we can improve that social care pathway in terms of better integration, health and social care, expanding social care capacity in the role of the sector, role of the voluntary sector, sorry.
Yeah, very happy to do that. So I might start with that, and then I might just check if Robin would want to add anything to that position as well. So in terms of you asked about social care. As a system and as an organisation, we monitor the number of, as an example, we monitor the number of patients who have what the NHS term to be no criteria to reside, and within that, the number of patients who are in either a P1, P2 or P3 category, which is a subset of that overall no criteria to reside. P1 patients are those patients who've been finished acute hospital care but waiting for some form of care in the home environment to support them at home. P2 and P3 patients would be waiting for some form of reablement or, care or long-term residential nursing or dementia care. So we, as an organisation and as a system, absolutely have oversight day by day on the number of patients that would be in each of those criteria. Depending on the criteria of care that they're waiting for, that may be provided through social care, it may be provided through NHS commissioned care, or may be provided through support from the voluntary sector, or in some cases a combination of all three. So when we see an increase in patients with no criteria to reside, it can be impacted by the capacity in any of those areas. I think what we have seen is an increase in no criteria to reside in P1, P2 and in P3 patients. That has just started to improve over the last couple of days. Too early to say that would be a trend to continue, hence alerting to board the challenge we've seen the increase in that over a period of time. Robin, is there anything you'd want to add in terms of how we have oversight of those issues?
Thank you, Steve. Thank you, Richard. So, as Steve says, we have a system-wide system control centre, command centre, where we come together, adult social care members of that, along with CFT and other partner organisations, and that's every single day. And in there, we've got a core set of data sets that we work our way through. We've implemented a new software product that's being used nationally called Shrewd. We're still in the place of making more use of that, but that gives us much more transparency at our fingertips. But our colleagues come to those meetings and they will say our patient names of who they're managing on our hospital site. So we're able to have that patient level dialogue on what's the plan, what's the timescale, who's doing what with these patients. That also, as Steve says, facilitates us having more of an understanding of have we got a capacity gap or not. You mentioned specifically, Richard, the voluntary sector. There's a couple of key organisations. One's called Chaos, one's called Humans, but there's many, of course. They actually have time on our site, and their teams are on shoulder to shoulder with our colleagues, supporting our colleagues, understanding what can be delivered by the voluntary sector, and also making some assessments and helping move patients on and through the system. We've got many other networks that we use as well to tap into voluntary organisations to support our flow out, but we are conscious of where we might be able to do more with that. And we have one other key part of our movement is we have these services called integrated transfer of care hubs, so ITOCs. There's 3 of them across Cornwall, and they're designated to work at place level. And any patient that's got what we call an onward care need would get referred into an ITOC, and the ITOC then have the web of contacts out into social care and the voluntary sector. And they're able to take the referrals, not just from us, but other parts of the system, and coordinate that system resource to make sure that we're using it to its full.
That's really helpful. I think you wanted to elevate the changing places point.
Yes.
Richard, did you want to say something?
Please. I mean, so I've got background noise, and maybe I'll come back to that. Let's finish. I'll carry on now. I mean, I think it's so important because being able to use a toilet is a basic human right and gives people dignity. So it's really important to note that about the changes in terms of changing place toilets, and it's good it's on the same level and it's nearer to the entrance, and so it's accessible to other key facilities. My question is have we got a communications plan to promote this to patients? And it'd be great to have photography on the website to showcase the facilities. And have we registered the toilet so it's added to the Changing Place UK maps?
Really important question, Richard. I might ask Kim if Kim doesn't mind commenting on that.
Yeah, so Richard, we were one of the first that joined some of the Saving Places initiative, and that's grown. Yes, there'll be an updated comms coming out. We have regular checks of all of the facilities, in ensuring that people are able to get the right key or code or whatever, and we go back out through all of our carers boards, safeguarding boards, the integration, just to make sure the most vulnerable of our communities know that it's there. There's also signage up in different places which we regularly review as well, and then they are part of our wonderful champs, who are a very, very energetic group of young people who have learning disabilities and autism. That's part of one of their peer reviews, as well as when we go out, are we communicating it properly? Can they access it? And most importantly, it's checked regularly and documented because of the equipment, and making sure that everything is fully functional and safe.
Thank you for raising, Richard. Really, really helpful. Isabel, you're next.
Thank you, and thank you, Steve, for your report. It was really just an invitation to see whether you might like to say a little bit more about the front end of the hospital. I know we've been talking about the delayed discharges, but I'm also aware that there's a huge amount of effort going into prevention of patients actually arriving at our emergency department. I just wondered whether you might want to just give some indication, particularly to members of the public who might be joining today, to say what efforts are going on to try to look at alternatives.
Yeah, that's a really important part of supporting Royal Cornwall Hospital, supporting the emergency department. So there's been some really significant work underway, which progressed rapidly across the system to provide, exactly as you're describing, alternatives to the emergency department. So if I give a couple of examples, we as a system have implemented recently a frailty same-day emergency care facility at Bodmin Hospital. That started to work a couple of months ago, with an intention that we would then start to move with a second frailty same-day emergency care facility, and then a third, to have 3 locations across the county over the course of this calendar year. So Bodmin was the first site to be opened. We are progressing plans and options for a second site, which would be at West Cornwall Hospital later in the summer, and then a third site, potentially Camborne Redruth Community Hospital, before we get into the kind of particularly challenging winter period. Those 3 sites, once they're operational, will provide an alternative for some patients who are frail elderly, who require care and support, but don't necessarily require that to be an emergency department. And one of our highest volume of patients coming into our facilities is frail elderly patients with a range of medical or support needs. So there is a really significant potential there to firstly reduce demand coming into the hospital, but secondly, that might also have an impact on the question that Richard asked a little bit earlier on about patients waiting for discharge support out of the hospital. If we're able to address some of that increasing demand, that can have a positive impact on reducing longer term care needs for those patients as well. So benefits directly to the patients, but benefits to our kind of wider system as well. Other interventions have included things like mobile X-ray diagnostic facilities. So one of the other innovations that have been progressed is the mobile X-ray car, to provide the opportunity to deliver X-ray diagnostic access outside of a hospital environment, including at times in patients' homes. So of course, some patients will need to come to an emergency department due to other complicating factors, but in some instances, that's enabled patients to receive an X-ray diagnosis at their own home and have an onward package of support identified there, rather than coming to hospital in the first place. And that can often mean a much more rapid access to the diagnostics, rather than a long wait in an emergency department or elsewhere. there are a number of other actions across the whole system which are designed to enable an alternative to the emergency department, so that we can then protect the emergency department just for those people who need that emergency department intervention. There are a range of actions underway across the system to support discharge out of the hospital as well. And of course, as we discussed many times in the board, a huge amount of work within Royal Cornwall hospitals to identify opportunities and actions to improve patient flow within our hospitals. And for our internal mechanisms to work as effectively as they can. And it's those three programmes of work together, the pre-hospital work, the in-hospital work, and the system transformation to support discharge together, that gives us, I think, the best chance to see further improvements in urgent and emergency care performance.
Yeah, really, really comprehensive answer. Thanks for asking the question, Isabel. And I think the other thing to say is it's also much nicer for frail older people not to be in the emergency department. It's just not a very helpful environment there if you're not an absolute emergency. So I think there's a thing about quality of care as well, which is really helpful. So, Steve, thank you for your report. I don't think anybody else is indicating to speak. So we're asked to receive and note the report, to note the update on the governance improvement programme. We're also asked to approve the submission of the annual certificate in the form of that Steve referred to in his report. And we're going to note, excuse me, that the submission will be signed by the Chief Exec on behalf of the board, and the certificate will be published on the Trust's website. So if people could just note and approve that submission, I would be grateful. That then moves us into the safe and high quality care part of our agenda. And if I could just remind us all that our committees work on the behalf of the board, and they do a great deal of the heavy lifting. And so we ask the committee chairs to bring their report to the board. And in terms of the director's presentation, directors don't need to repeat the same introductions that they made to committee. But of course, if there is further information that you want to report to board, then we're very pleased to hear that. Isabel, could you please be the first one and give us the Quality Assurance Committee report?
Thank you, Mary. Thank you. I think when I looked at the agenda for today, it always surprises me just how many items fall under the remit of quality. So the board will see the papers that follow have had prior discussion and scrutiny, I guess, through our Quality Assurance Committee. For today's meeting, what we're talking about really is the items that were raised and discussed and recommendations coming from the May and June Quality Assurance Committee meetings, both for Royal Cornwall Hospitals Trust, but also in the Part 2 meeting, which we have with our colleagues at Cornwall Partnership Trust. So I think the areas that we really want to focus on, I think, are those where we're not unable to give full assurance around issues, and where there are issues around partial assurance, which will remain under the scrutiny of the Quality Committee going forward. And some of those I can itemise as work relating to 7-day services, which I know already appears on the action log for today, and will be coming back to our Quality Committee in September. The pressure ulcer improvement plan, where we're seeking greater assurance around training for temporary workforce around pressure ulcers. And I think the other area probably is around our health inequalities report, which comes to board as well, where at the moment we would like to see greater progress around that. And that is obviously dependent on the ability to engage well with our partners within the wider system. There are two areas that I wanted to bring to board in terms of escalation today. The first, which came up in our most recent meeting, regarding the number of medical vacancies that appear to be sitting within our budgets within care groups. So we're not necessarily seeing full recruitment taking place around some really important and necessary medical vacancies. So we're seeking further assurance around that. We're escalating to board so that board is aware that actually this is an issue that we do need to address with some pace, I think, in order to be able to cope with what we know is going to be a really demanding year ahead. We want to make sure that we've got our workforce as fully recruited to as possible. So that's one area that we're escalating for the board to consider. And I think the second area is around the report that we submit for the Care Quality Commission, looking at the improvements that the Care Quality Commission have indicated are must-dos. So that again relates back to our medical vacancies. And then in addition, we are also undertaking some work around the lack of assurance around fire safety training. We are waiting, and we have been waiting for the last couple of meetings for a report to come to our committee to give us assurance that actually the fire safety training is as it should be. And it's something I think that was flagged up, I've got a feeling, through the audit committee as well. So we are just escalating for board's awareness that we need to actually ensure that next month when we meet, that we do gain assurance around the level of fire safety training, which is pretty critical. I think that we're being asked also to engage with work around paediatric audiology, which is a national piece of work looking at the quality of the services that we're providing for our children and young people in terms of hearing. And you'll see that there's a lot of information on the board today around that, which is great. And I think the final thing I wanted to just say was that we are now into our second meeting with our system colleagues looking at service improvement and quality. And we are looking at some very detailed work around diabetes, looking at the entire pathway for diabetic patients and pre-diabetes, again talking back to the prevention agenda that I mentioned earlier. And issues that were raised in the initial meeting of that committee, the service committee, were around stroke and cardiology. And again, that committee will be keeping a watchful eye on progress around work looking at the entire pathway around stroke, and also reporting back on cardiology. And that's not to say that those items won't come back to our own committee in-house. They will come back as appropriate to the need to discuss and scrutinise those issues. So I think that probably summarises the key points that I wanted to raise from May and June. But I'm happy, certainly with assistance from people like Kim and Alistair, to answer any questions that the board might have.
Yeah, thank you very much indeed, Isabel. It was a comprehensive report, and it does represent, I think, to the board and to the public just how much work your committee does. So our thanks to you for that. I would like us to, I see Kim, thank you, you've got your hand up. I would like us to address the issues you've escalated to the board so that we can determine what's going to happen next about those. And perhaps you're going to pick one of those up, Kim, but you're wanting to come in.
Yeah, just to we know that we get regular reports on our CQC position. We know we've got our improvement plans, but we had a really good discussion around the four. You know, we've still got 4 must-do actions to complete, and you'll see the triangulation that actually, as Isabel said, one is around medical staffing, and it isn't just recruitment, it's the resilience to be able to maintain that. So it's recruitment and retention. Closely linked to that, whilst this was as regards our urgent and emergency care medical staff and compliance against mandatory training, which is difficult if you haven't got the resilience and you've recruited, it's linked, but there is that wider statutory and essential training compliance trust-wide, and I know that Pod and Alison continue to look at that, but I suppose it's how do we get, whilst we're seeing that increase, how do we get to over 90%, which is a continued challenge. And the other 2 are closely linked to nursing recruitment, both registered and unregistered, especially in our, what I would call our urgent and emergency services, and especially against the more skilled clinical roles, and then that ability then to release for the ever-growing list of mandatory and essential training. So we do, but both with Pod, and I can see Alison's hand's gone up, but also QAP, because these are quality and safety issues. And Isabel led a very comprehensive and robust discussion, and Richard Stevenson, our other Ned, also joined in. We had a really good discussion as regards Overdue incidents. As you can see, as of the 17th of June, we had 763, which led to quite a lively discussion about could we understand our position? So looking across the board, you know, what's the benchmark? The short answer, I think, from our experts is no, we couldn't without doing a manual trawl and reach out. But I think I think we got into a really good discussion about our approach being risk-based and the management of these overdue issues. And 763 do sound alarming. Most of the majority of them are low-lying level risks. So we have we had just started the work, but we've made it more robust. It will be coming back through QUAC. We're looking at the 17 what I would call higher risk incidents as a start. The overall management, because this is care group business, the majority of those sit with corporate estates and facilities, and one is quite historical. So we've taken that up with our new director, Brian, to make sure that we've got a robust plan around those. And for those members of Audit and Risk Committee, it's no surprise that some of these sit linked to the outstanding actions that we're working on through some of the audit reviews. So we're doing there's a short task. It's not a short task and finish group. It's those people that are involved in the monitoring of this with the care groups, looking at these, and we're going to bring a robust plan back to quality and assurance. But with many things we discussed, I didn't want Isabel to miss an opportunity to say that there was a very, very good and lively discussion around the management of this, and that's what will come back through.
Thank you very much, Kim. And I'll bring Alison in. But can the board have assurance that those matters which have been escalated and you've referred to will therefore be being picked up in that work that you're coming back to the committee?
Yes, we will do that cross-check with fellow chairs and colleagues about what's coming, what POD is taking forward, and then the connection between what QUAC then reports through without duplicating, and of course the incidents and the CQC other actions.
That's really helpful. Thank you very much. Alison, I think you're wanting to pick that up.
Yes, thank you, Chair. So I just wanted to comment, first of all, around medical resourcing. I agreed last night, given the challenge that we've got on our recovery plans on the medical side of things, with Helen Wilding, who's the Deputy Director of HR in CFT, that the Workforce Efficiency Programme, in particular Jack Henniker and team, will focus primarily over the next couple of months on helping to plug those gaps and put in plans for recovery on medical roles. So that's something, being in a dual role, that I've been able to navigate, as I say, with Helen. So I'm feeling more assured that we can support Jackie from a resourcing perspective from RCHT by having that additional resource. So that was the first thing I wanted to say. Second thing is on statutory and essential training. Now, working with Robin, who holds the exec portfolio for fire, obviously fire training, essential training is a must do. We've got Helen Lewis represented at national level, looking at how we simplify what is essential training, but fire is never going to be off the list. So compliance, if I just say on essential training, and I know we'll get to this later in the report, but compliance on essential training for statutory mandatory was at 71% in January 23. We're now at 83% as a trust, and there are several care groups that are and some corporate areas that are over 90%. But saying that, as I say, it is really, really important that fire training is at the, everybody needs to have fire training. So I know my exec colleagues will continue to support me in championing that message.
Thank you very much, Alison. Isabel, I know you want to come back in, but I think I had Alistair's hand go up just before yours. Alistair?
Yeah, thank you. And it's great to hear, Alison, that you're going to get extra support in terms of the medical staffing recruitment retention. I think it's really important to note that whilst if you look at RIPR integrated performance report in terms of medical vacancies, we're doing really well in terms of medical vacancies, but there are particular hotspots across the trust where we for a long time have not been able to recruit into key posts, and a number of those are in what we would consider key medical specialties which affect flow across the hospital. So a real focus on that is absolutely needed, both for flow in the hospital but also for well-being of those teams who have been under a lot of pressure over what I would consider a considerable period of time. And the other thing that really, which is a byproduct of that, is that we know that our nursing teams have done really well in terms of reducing the amount of agency that we use within the hospital and reducing costs. I think because of some of these very niche vacancies that we have in medical staffing, we are now seeing that the use of medical agency is now a significantly higher proportion because we haven't been able to recruit or retain into some of these key areas. So I think the focus on this is absolutely right at this time. Thanks.
Thank you. And perhaps, Isabel, just before bringing you in, as to what that prompts in my mind, and I'm sure you're all looking at this, but prompts in my mind whether these vacancies have to be filled with medically qualified people, or whether there's some parts of the work that might be done by other people.
Yeah, it's a really good question, and I think for some services we've absolutely been doing that over many years. So we've developed allied nursing roles. We have nurse specialists and acute care practitioners who are taking some of the pressure off some of those lower level cases, but there's no doubt that we still need a core number of consultants for some of these services. And specifically, I'm thinking about care of the elderly, acute medicine, neurology, stroke, areas where we really do need to focus. So yeah, be in no doubt we are using every alternative method to relieve the pressure on those services, but we still do need that consultant workforce.
Thanks very much, Alistair. Isabel?
Yeah, I just put my hand down because Alistair's more or less answered, I think, the point I was going to make. But I think there's also something that the board might want to consider in some of these really critical frontline areas that are affecting flow through the hospital, where there may be budgetary constraints within one care group around the level of recruitment that can take place, and where they are hard to recruit to posts. Should we be fortunate enough to have several candidates applying, and at the moment we've only got room for one or two, whether there is some merit in having a debate about reallocation of resource so that we can actually in some instances over recruit. That would be something for the executive to consider, I suppose.
Thank you, Steve.
Yeah, that's a really helpful suggestion, Isabel. That has happened in a couple of individual cases where executive colleagues have considered that position, and that might have been what Ian was going to comment on. I don't think we've reported in those instances. I don't think we've necessarily reported them back to board, and potentially we could do that, or back to a relevant committee. And as part of that, test whether that's happening at a significant enough scale. But certainly there have been a couple of examples this year where that opportunity has arisen, and executive colleagues with their care group colleagues and clinical leads have secured those kind of opportunities.
Thank you.
Thanks very much. Thank you, Steve. So in terms of what's being escalated, I think, Lindsay, you'll have a good note of how we're managing that. Just before we move on as briefly as possible to the reports there, I was wondering how, under the health inequalities report, how are we working with our colleagues in social care around the capacity of children in care services? Because that was quite alarming to read. And so what are the mechanisms, Kim?
Yeah, so this is going to go to the clinical reference group system wide, but I have raised it with our colleagues in the system, because this is a service that is a system-wide service and commissioned, and for many reasons, including the number of unaccompanied minors that Cornwall and the Isles of Scilly have seen enter our services, and the very complex needs. This is a service that was never commissioned to see the levels of activity that we're now undertaking. We are closely monitoring, and Alistair and I recently, through our new meeting that we consider our high risk equality and quality impact assessments, went through it with the team. The team are working above and beyond to make sure, and working with collectively with our partners to make sure that we keep things as safe as possible, but it means that we are still not achieving the statutory targets that we need to be able to take. So we will be taking this further through our commissioning investment and our quality system-wide groups.
Thank you. Thank you very much. That's helpful. Isabel, do you feel that's a fair response?
Yes, thank you. And apologies for not raising the issue around children in care under the health inequalities. I'd actually made a note of it and then completely ignored it when I came to look at my notes. So apologies for that. And thank you, Kim, for responding. I think we've had a good conversation, and hopefully some suggestions about how we tackle the elements that we've escalated to board today. So thank you.
That's great. Thank you, Isabel. And I think just to comment on that, the discussion around who does which jobs in our hospitals, I think that looking to the future and looking to the general need for not just medics, but all sorts of people in our economy, I think we are going to have to start thinking harder, even than we are already, about who does what, and that we just see the resources as scarce resources and apply them carefully. But thank you for the discussion. I'm going to ask us, if possible, to go fairly succinctly through the next reports under 8. They have all been well discussed, but I do want the board to have a chance to hear from them. So if I could go to 8.1, Kim, please.
Oh, sorry, I couldn't get myself off mute for a moment. As you say, Chair, I'm going to take it as read. I have had a few questions, so I will cover those as I briefly go through. You can see that the data is the month of May. We had 3 patient safety incidents, and for the clinical ones amongst us, but for most importantly for the non-clinical, case 2 is really complex. And if you look at the nature of the injury received during birth and the appeared lag in date, what I would like to assure you is that the person concerned, without betraying any confidence, is being fully supported. There are many complex reasons that I'm happy to pick up outside of this meeting, but they now have a scheduled multidisciplinary, because this injury will need more than one specialty, booked for July the 24th. So, but I'm not at liberty to say more than that under the circumstances, but happy to pick it up. And there is this, the family concerned are happy to share this wider, because there's much learning in for everyone, and it isn't just it's a system-wide learning issue, is what I will say, and we will pick it up from there. I'm pleased to note there were no stillbirths. Please, if you will note the updated position against Euroking, which was the national IT system, and our anticipated revised compliance, which is closely monitored through our neonatal and safety champions meeting and QUAC. Calvin and the team are supporting the maternity and neonates e-care position as regards some of the concerns that were raised, but we're working through how we address those. The birth trauma inquiry had 12 recommendations, 4 of which we will be focusing on and encompassing within our current maternity improvement plan. And it's important to note that it's really disappointing to see the reoccurring themes. Lots of work we've already done on those, hence why only 4 we believed need refreshing. This was a national birth trauma inquiry. Whilst there was no specific EDI, which is a diversity and equality issues, they were universal. We won't lose that in our translation of the communities we find ourselves in. The National Learning from Maternity and Newborn Safety Investigation, there was 2 further pieces of work we thought we could focus on, which has been added to our maternity improvement programme. You will see that the team picked up an anomaly in recording of appraisals for new starters. They are working with the relevant team because it will affect all. It won't just be contained in maternity. So that's been picked up as a trust-wide action. And I know that the training deadline for in September 25 sounds a long way away, but because of our CNST registration, Saving Babies' Lives maternity improvement plan, we have to do a full year all staff compliance. And that is why we've got to book everyone in, have a month-by-month plan, and have that commitment to be able to do that by that deadline date. But any movement off plan, I would obviously escalate before then. And then, of course, no surprise, and we've spoken about already, it's the staffing actions, especially as we move into our biannual staffing report trust-wide. So maternity have got Birth Rate Plus, which has been completed. It's externally done, so we have that external influence. And the neonatal staffing, there's no current tool, but we're going to use the neonatal workforce tool of 2020 with some of the closures, our continued work to fill vacancies. We're just going to do a full audit of skills, competencies and numbers, which will be part of the biannual staffing report. And I will leave it there, Chair.
Thank you. That was a really comprehensive expansion of that report, which, as we all know, does need to come to board. So really, really grateful for that. And please forgive me, I just wondered, you know, the anomaly around the recording of appraisals and so on. Would that be affecting other areas of the trust, or do we think it isn't?
No, it will, Maury. That's why we've picked it up with one of Alison's teams to make sure that we're not just rectifying it in maternity and neonates and women and children's, but that wider trust-wide approach.
Thank you. I'm sorry if I missed you saying that.
That's okay.
Really helpful. Are there other questions for Kim on this report? Isabel.
Apologies, yes, I'll be very brief, but it was a question really about future staffing and just to seek some assurance that in the conversations that are taking place around how to address shortfalls, that we're taking into account the longer term look in relation to the new Women's and Children's Hospital.
Yes, Isabel, we are. So part of the Birth Rate Plus team, we didn't just look at the here and now, we did some scoping as regards what would the new build staffing look like. And indications were with the falling birth rate at the moment, we're in a very good position, and that will be part of the biannual safer staffing report that you'll see. So we're not just looking at the here and now. And I'm delighted to say, once again, we have a short waiting list for our midwifery posts, which we're going back through to make sure we don't lose anyone, and where can we build up some further resilience.
Thank you, Kim.
Thank you very, very much. So, and thank you, Ian, for your note in the chat there about ICB colleagues' funding arrangements for children in care. Appreciate that. I was slightly distracted by the discussion in the chat around quality and safety and finance, and I think that really is something that we perhaps need to pursue later on this afternoon, because clearly we have that tension. And we're needing to find solutions. So could I ask colleagues then if we could note the current service provision in relation to the Euroking patient safety alert. Sorry, just my screen's just decided to desert me, but I'll come back to it. I'm sure I'll find it here somewhere. Yeah. So I'm sorry about this, my screen went blank. Also to discuss and note the findings of the service gap analysis undertaken against the National All-Party Parliamentary Group on birth trauma. The findings also of the services gap undertaken against the Maternity Neonatal Safety Investigation National Learning Report, the current state review of e-care for maternity services and next steps, and the current position with the outputs of the National Neonatal Nursing Workforce Tool. So if people could just note those, I'll go on to item 8.2. Alistair.
Yes, thank you, Mary. So this is a Q4 Learning from Deaths report. You'll all be aware that our Mortality Review and Oversight Group, who meet on a monthly basis, triangulate all our information related to deaths and work really closely with our medical examiners, who are a group of independent clinicians run through the coroner's office, who oversee the certification of all deaths in Cornwall. We use the information from multiple sources, as well as our mortality statistics, the crude mortality, HSMR and SHME, and it's pleasing to note that all of our mortality statistics have improved over the course of the last year and are stable, and our crude mortality is continuing to fall. We benchmark well related to the rest of the South West trusts, and for this report we've also this year started to benchmark us against other rural trusts, and again we benchmark well. Locally, we've had a number of alerts in mortality which have come and gone over the course of the year and over the last quarter. Our most significant concerns have been around stroke and fractured neck of femur. For the last quarter, the stroke mortality has fallen to under 100, which puts us below the median, which is great to see. But fractured neck of femur mortality is one of our pathways where we remain concerned. We have a number of metrics which we pull from the National Hip Fracture Database, and 3 out of the 4 of those key metrics have deteriorated in this quarter. The first one is admission to a trauma unit within 4 hours. This has deteriorated slightly, but actually, even though our admission to the trauma unit is only in the order of 20 to 30% within 4 hours, that still, interestingly, nationally puts us in the top quartile, whereas the national average for getting into a trauma bed within 4 hours is, I believe, 9%. The one that we're really concerned about is that getting to that surgical intervention within 36 hours of arriving in the emergency department. And we have set up a quality improvement workshop to specifically look at this particular metric, which will take place in August, and we're keenly focused on those. There are our medical examiner service is fully recruited, but there are some interesting and updates to the death certification process. These this process hasn't changed in the last 50 years. So this is a brand new change, which will mean that there'll be changes to the way that doctors are contacted for the medical certificate of death. There'll be a new paper certificate with plans to replace that by a digital certificate in due course. And historically, there's been part 1 and part 2 of the certificate, and then a cremation process thereafter, and all of that will be combined into one form. So that's being worked through by our medical examiners. Other key points over the last year, we've had 3 Regulation 28s, and those relate to one to a steroid medication error, one to thrombolysis prevention, which was related to an orthopedic case, and one related to the fact that on one of our wards we had dual ways of recording medical inpatient progress, digital and paper. So we've made changes related to all 3 of those prevention of future deaths, section 28. The rest of the paper is as we would normally report quarterly. I guess new for this paper is also the inclusion of a number of quality improvement initiatives that are taking place, which potentially have a specific relationship with mortality, and those will be the outcomes of those will be reported going forward. And likewise, we've also included in this latest report in section 9.6 any national audits which are specifically related to mortality. And in this report, we've got the NACEL audit, which is the National Audit for Care of the End of Life, and also the Society for Acute Medicine benchmarking audit, which has some interesting data. So I'm happy to leave those as the key points to pull out of this report. Happy to take any.
Thank you. Thank you very much, Alistair. It's nice to see those additional points. Kim, you're wanting to come in.
Yeah, Alistair, I don't know if you wanted to include the end-to-end stroke pathway discussion we had at the first System Improvement and Quality Group.
Yeah, so I think we have, as you may or may not be aware, we have a system-wide stroke improvement board, which has been co-chaired by the ICB and by Bernie George. That also dovetails into some work that I've been doing on a peninsula-wide basis with the integrated stroke delivery network across Devon and Cornwall, that related to access to thrombolysis, which is the clot busting for stroke, and also thrombectomy, which is the mechanical removal of clots from patients' brains using radiological techniques. So there is a lot of work going on across the stroke pathway, both locally within RCHT, within our ICB, and across the Acute Provider Collaborative, which is Devon and Cornwall initiatives.
Thank you. Richard Stevenson.
Thank you, Alistair. And we discussed this well at Quality Assurance Committee, but I just wondered if you could say a little bit about 9.2, the quality improvements, because that's really helpful inclusion, I think, into the report, and the list table that's there is really helpful. I just wondered, to what extent are those projects driven by personal interest of clinicians versus a strategic programme of quality improvement projects? Just not clear how we derive those areas.
So I think a number of these are driven by some of our key performance indicators. You know, for instance, the blood pressure management for acute strokes is driven by that particular project. Some of them will be the equivalent of some of our middle grade doctors, registrars doing quality improvement projects because of the particular interest in an area of that, and some of it, but the majority of these, I think, for instance, the standardising weekend ward jobs on call jobs for doctors, that's part of our part of our improvements in flow discharge summaries for deceased patients. That's looking at a particular type of way of doing discharge summaries for patients at end of life, so something called a great discharge, and that's part of a national programme which local end of life care teams are focusing, and a clinical fellow has taken particular interest in doing that. So it is a mixture, but a lot of this is driven by our key performance standards, our key concerns around the standard and quality of care that we deliver.
Thank you. Thanks, Richard. Robin.
Thank you, Mary and Alistair. Just picking up on Kim's point with the stroke piece in your comment, Alistair, I think we need to also frame in the acute, we've extended our bed base. So our Phoenix ward, our stroke ward, is normally 21 beds. Through our extreme escalation actions that we've been taking as an organisation, that's currently extended to 25 beds. And linking that through to the system-wide actions, I think there's a need for us to reassess ourselves how well we've made and are using something called early supported discharge, it's known as ESD, and that can prove some quite good results in terms of freeing up capacity in bedded establishments. So that would be us and our community partners, but also gets patients home quicker. And as we make more use of something like ESD, that gives us more capacity for patients to be accessing the stroke unit within 4 hours. And save the conversation when we get to the IPR, colleagues will see that, integrated performance report, colleagues will see those stroke indices there. And one of a really significant part of moving our stroke score, SNAP score, please don't ask me to remember what the acronym stands for, moving our SNAP score up, is getting that direct access to the stroke unit within 4 hours, because a lot of the other onward actions build from that point. So we're very determined in the acute for having that direct access to the stroke unit. We're very clear about ring fencing the bed base on the stroke unit. So we will tolerate an empty bed on the stroke unit when we've got pressured ED, because of the importance of a stroke patient accessing that care to facilitate this. But those actions from how we can make better use in the wider community should be able to drive those performance indicators, which then has a known benefit to outcomes for patients linking through to this very report.
So, Robin, thank you very much. Richard Kay.
I just wanted to ask about 9.5, which is deaths and non-people with a learning disability. And I noted that it seemed to be an older age group presenting. So I just wanted to know, was that reflected in the national trend, the yearly annual trends for the trust?
That's a good question, Richard. We frequently in this section see a mixture of younger and older adults and children with learning disability and autism. I can't tell you whether there's a particular trend in those, so I'll have to take that away and ask the team to look at that.
Will you be able to bring that back, Alistair?
Yeah, we can put that into the next learning from deaths report. That would seem sensible.
Thank you very much. Ian, thank you for your note. No, I couldn't see your hand, so in you come.
Thank you, Chair. Just a couple of quick ones, conscious of time. So the changes to death certification, Alistair, just in summary, do we think overall that will be a positive benefit in terms of freeing up clinical time to care for patients was one question. And then my other one was just, I noted the significant increase in the number of our staff that have been called to inquests, and just to check that we've got, through the appropriate committees, support for those staff, because that's doubled between 22-23 and 23-24, and clearly that, I imagine, is quite a difficult experience to go through in some of our complex inquests that our teams have to attend.
Yeah, thank you.
It looks like you want to come in.
Oh, sorry, Alistair. Yeah, we have very comprehensive multi-professional support, and that Ian fits in with some of the pressures that's on a very small legal team due to the number and the complex cases coming through, which was why we did that temporary support, and it came up through investment committee. But yes, and Alistair and I keep a very close eye on which cases are going through, and make sure that all staff have that debriefing as well afterwards.
Yeah, we do. We had a good conversation at the Quality Assurance Committee about exactly that issue, Ian. So yeah, we do actively manage that. We know that this, for some of our staff, they've been to coroner's court lots of times and they understand the process, but for some it can be really daunting and it can be frightening, but it doesn't need to be. So yeah, we absolutely support. Going back to your other question, which is about the reforms, I think the reforms themselves will, I think, help the process, especially when it becomes digital in due course. The issue, I think, it will be specifically for the medical examiner's office. So this is going live later this year, but also you'll be aware that all deaths within Cornwall and the Isles of Scilly are being, by September, are going to go through the medical examiner's office. All deaths in RCHT already do. The medical examiner's office are expecting at that point a potential 50% increase in the number of cases that they get involved with, and as a result of putting in a new process by which those deaths are actually reported to them. So it'll be through our current electronic systems, and then in the future through our new EPR systems when they come in. So this is something that the medical examiner's office are currently working on with me and with all the teams about how we can streamline that so that it's as efficient as it can be, but it will need some tweaking, I think, over the next few months.
Thank you. Thanks very much. So on 8.2, can we note that Q4 the assurance report, and colleagues move on as swiftly as you can, because these matters have had good discussion, or the other items. I was hoping to get us a quick coffee break before our IPR, so let's see how we can do. Rob, health and safety annual report, excuse me.
Challenge accepted, Mary, thank you. So I know the report is read. Highlights for me are the improvement plan remains on track. Draw to colleagues' attention the reporting of incidents and diseases, dangerous occurrences regulations, so known as RIDDOR. We're actually seeing an increase in RIDDOR reports, but that's intended, and we're pleased to see that because of the work we've been doing with our occupational health colleagues and general awareness of the need to highlight these things. So at the moment, we are pleased to see an upward trend. Through the Health and Safety Committee, we will be working on the point at which the sweet spot is achieved and when we should start to see us operating in a window that we feel is appropriate. Please, colleagues, note that we continue to be well under the minimum standards required for reducing exposure to our staff for nitrous oxide. That really has been a success story for us, and that monitoring remains in place and continues to be the case. I do want to make sure that I'm highlighting to the board that we've had 3 interventions over the last year from the Health and Safety Executive. All now have had supporting evidence submitted to the Health and Safety Executive, having responded to them. So in reverse order, the most recent one was the pathology category 3 laboratory, and there were issues with regards to training of staff. Staff have been on the relevant training courses and certificates provided back to the Health and Safety Executive. They're currently assessing our evidence. Asbestos, it was a control of contractor challenge that we had at West Cornwall Hospital. There's been amendments to the controls of contractors as a result, and also we've made further updates to our asbestos register to make it less likely that that would reoccur. And there was a regulations regarding radiation protection, particularly around contingency plans, health and safety arrangements, and our supervisors. Again, all of the training and changes have been put in place to manage that. and also in the interest of full transparency to colleagues and individuals watching, our control of substances hazardous to health, known as COSH. We had 2 instances in the last year where we've received notices of contravention, and we're currently concluding our action plans to prevent reoccurrence as a result. We have been undertaking over the last year enhanced COSH training across all of our staff to prevent these types of instances from occurring. Thank you, Mary.
Thank you very much, Rob. Again, comprehensive and important things for us to note. Are there questions for Robin? Yeah, Aled?
Thanks, Mary. Well, it's an observation really that it's really good to see the safety performance largely stay static, if not improved in areas. And for me, it's always an indicative kind of point to triangulate with some of our discussions around staffing, because some of these, even though they're health and safety outcomes, they're actually intrinsically linked to safe staffing levels. Things like sharps injuries, slips and falls, moving and handling are all indicators indirectly of staffing. So that's a good thing to pick up on and to report. I can see there's slight upticks in some places, increases in some places, but they are largely minimal. My question though is around, given that we are covering fire safety elsewhere during board this month, I'm just wondering why fire safety doesn't come under trust, health and safety performance. That might be my misunderstanding of some of the legislation or statutory requirements around reporting, but is that something that's missing or should be referenced here, for example?
So we did discuss fire safety in the Health and Safety Committee to avoid duplication of reports, because we have the dedicated fire report. You get that in a dedicated report that Steve's going to talk to in a moment. But I can assure the board that on our Health and Safety Committee agenda, we receive the report in from Steve Hill's team from a fire safety perspective, because you're right, Aled, it does all ultimately come under the umbrella of our requirements from a health and safety perspective on our sites for our staff, patients and visitors.
Thank you.
Thank you, colleagues. Are there any other points? I'd just like to thank you actually for all the work that goes into all of this, Robin. You know, there's a lot of work behind this, so I appreciate what's being done. Can I ask us then, please, to receive and note this health and safety report, and then move on to welcoming you, Steve Hill. I'm really sorry that we've kept you waiting a little longer than you might have expected. I gather you're here on behalf of Brian Johnson to help us with the 8.4 fire annual report. So, are you there, Steve?
I'm yes.
Great.
I hope you can hear me. Good morning, everybody. No, but the paper has been submitted already, but just a quick few highlight points for me, if I can. It's again another very productive year for the fire safety team and fire safety improvements that we do across the trust. It is the function of the trust to understand the risks that it holds and how we best mitigate them through either training or through projects, and some of those projects are very time consuming and costly. One of the main things, one of the main points that we're looking at then is the Tower Fire Safety Improvement Works programme. That's an 8-year programme with 10 phases. Currently, hopefully about to start phase 6, but phase 1 to 5 is now complete, and year 23-24, phase 5 was completed at that point. Other areas where we're not just concentrating on the tower block, we also covering the main other sites as well. So plenty of new fire doors, fire stopping, as well as an extensive training package to mitigate some of those risks as well. I can go on to some of the key highlight points from the report. Really, it's just to talk about the actual fire safety training, which I know was mentioned earlier. So the main fire training is the annual mandatory training that everybody has to do, on top of which we do face-to-face training, and we look at the enhanced fire warden training, which is the biggest mitigator if we get a fire in any of our areas, but our staff are aware of what to do. We've got key players in directing that initial response. So over last year, we've done 503 individual fire warden extra on top of 351, which from the previous year. We had 226 individually trained for evacuation equipment, which is an increase from 23 from the previous year. Actual fire evac training, on ward training, 697 staff have been trained in that situation, what to do, walk through, talk through. With a total staff training number of 1,438, which is all face-to-face on top of the annual fire training, which is key to note. And when we talk about the annual fire alarm activations and calls, we hear the fire alarms going off now and again in the trust, and we try to keep them to a minimum, obviously. But manual call point activations is our biggest culprit, really, from the fire alarms going off in the trust. And this is a combination of people smelling smoke coming from external sources or smoke from within. Could be burnt toast or feel, or it could be a malicious activation from either a visitor or possibly a confused patient hitting the wrong manual call point. So this year we're up to 74, so that's a bit of an increase. And we know we've had an increase in certain ward areas where we've had particular patients with sort of confusion status and hit those call points trying to escape the area. We've had 15 faults, which is down from 35, which is indicative to the major upgrade in the fire alarm system, so we're doing across the trust. We've had 3 more cooking incidents this year, through burnt toast and regen trolleys being in inappropriate places. Again, working on that with education. Actual fires, glad to say no serious fires. We've had 3 this year. 1 small electrical fire, and the rest were from waste paper bins outside the building through careless cigarette discarding. And again, working with health and safety colleagues to try and reduce that amount. Total fire signals throughout the trust, 223, which is down 14 from last year, and actual fire service attendants when they come along to help us out and just make sure there's no issues is 61, and we've been actively driving that number down for fire service attendants, because what we don't want to do is waste the fire service time when there could be an actual incident. So we're very proactive in investigating the cause of the fires, over false alarms, making sure that we're content that we can stand down the fire service from attending. So we're very proactive in that as well. And really, the main big thing for me is also to thank the Trust Board for the continued support that they provide, the fire safety improvements that we're working through, and the training resources that we get. It all contributes to reducing our risk overall. So thank you. That's my summary report.
Thank you very much, Steve. Very, very comprehensive and helpful. It's really good to note all the work that's going on. This is something that used to keep me awake at night quite a lot, it is assuring to hear. Several years ago, it felt more like a mountain than a smaller hill to climb, but it's really great to hear the progress that's being made. So I thank you. I think I've got Alison and Ian wanting to come in.
I think it's Adrian first, actually, Chair.
Beg your pardon. Thank you very much. Adrian, Alison and Ian. Adrian.
Hi, Steve.
Hi.
My name's Adrian Davis, new non-exec with the Trust, and my background is in fire. I did 30 years in the fire service, so I anticipate speaking to you a fair bit in the coming weeks and months.
Look forward to it.
Really good report. You clarified a couple of the points that I was going to raise, but I wondered if we actually do any fire drills or exercises.
Yes, indeed. Yeah. So the major fire drills, if you like, so we would evacuate a whole ward, if you like, has to be done through simulation, or has to be done when a ward is closed. So the last recent one we done was back in October, where we had endoscopy ward, where we put simulated patients in there, and we done a complete horizontal evacuation and a vertical evacuation through smoke. We had the fire service with 8 appliances on scene, and talk about how we would interact from a command and control point of view to their command and control, and evacuating those patients to a relative place of safety and then to ultimate safety. So yeah, very well practiced. That's usually done once a year. But the actual on ward training, as you can imagine, is very difficult to disrupt the works, the good and important works there. So what we do is we take staff and we do a talk through evacuation with their fire wardens that are trained, and we do that on a every ward gets it done once a year.
Steve, if you get any more exercises where you're planning an evacuation, I'd very much like to come along as an observer if you could facilitate that.
Yeah, absolutely, more than welcome to come along.
Thank you very much. Ian next, then Alison, then Robin.
Thank you, Chair. So just to recognise, particularly on the tower works, Steve, so really good progress in terms of those phases. We have a separate item on our private board agenda this afternoon, but I think one of the things that we need to focus on around that is the current timescale for that, and obviously the pressure of kind of the cost of completing that work. So we've got significant commitment in this year's capital programme for the phase 6 works. And I think it's just really important as a board we keep close to what the time frame and cost exposure is on completing that really important piece of work that your report highlights. So I just wanted to reference that, Chair.
Absolutely, thank you, Ian, for that. Alison.
Thank you, Steve, for the report. My question is, I don't know whether I've been lucky or unlucky, because you can view this in two ways. But when I've been on call, a couple of times I've had false fire alarms, and the common denominator has been contractors and the work that they've been carrying out. Mm-hmm. Could you explain what we brief contractors when they come onto our site? Because, as I say, I'm not sure whether I've been lucky or unlucky in this respect.
I think you've been well, lucky to know that the problem does exist. Unlucky that you're on shift at the time. So we do comprehensively brief contractors if they're going to be doing any works that may affect our alarm systems or create a smell or an odour, like tarmacking, for example, outside, or line painting the car parks, that they obviously through the project management team, that's communicated back to the ward staff that may be affecting that area, and certainly that back to the state's operations, where we can make isolations to the alarm areas and make sure it's safe to do so. We have had in the past contractors not following those completely, but we have got a new contractor control process in place which eliminates some of that. And then we also get the contractors done absolutely everything correctly. We've informed people, we've put site-wide communications on, but there may be a smell coming through the windows because of line painting, but we'll still get people who are might not have read that message, still unaware that that process is going on, smell something they're not sure of, and they'll hit that manual call point, which is the correct thing to do. So yes, we will get that, and yes, it's easy to say, oh, contractors let us down again, and we've got a smell, and the alarm's gone off. So it's a balance, isn't it? We've got to have the contractors doing the work. They do create dust, they do create smells, and we try and educate as many people as we can about that. But we will get that system happening.
Thank you very much, Rob. You've taken your hand down. Is that because it's been covered?
Yeah, the conversation's moved on, Mary. It's fine. Thank you.
Perfect. Thank you very much. Are there further questions? In which case, Steve, can I thank you very much for your report and for presenting that. Excuse me, and invite board to receive and note the report, but also I would say, if we just add here, to note the significant progress that has been made, because it is significant. So thank you very much indeed. And you are very welcome to stay, as this is a public meeting, Steve, but I'm quite sure you've got better things to do. So thank you for being with us.
I'm not sure about better, but other things to do. Thank you very much.
Thank you for being with us. I appreciate it. Robin, 8.5.
8.5.
Summer season plan.
Of course. Yeah, sorry. We've got a really busy hospital site at the moment, so I'm a bit distracted with that at the same time. Apologies. So for colleagues, we are required to have a winter plan, but actually because of the amount of activity we see during the summer period, we as an organisation also undertake a summer plan. So we call it our seasonal plan, and it rolls with slightly different actions between the different seasons of the year. And I'll take the report as read, but essentially through here you can see that there's a range of actions we take in terms of our plans for managing heat waves, and in particular how we manage large public events, which really RCHT doesn't manage large public events. The whole MDT across our system manages a large public event, and you'll see some statistics in here about how successful that is. You know, there's a lot of people that jump to because there's a big event that's going to put lots of pressure on the health system. Actually, that mechanism that's multi-agency prevents pressure on the health system as a result. And you'll see in here that we've got specific actions around how we identify patients who we believe are less likely to be local resident, and then undertake an assessment. Is that the case? And if it is the case, how do we repatriate those patients back to their local hospitals? And I use my words really carefully there, because we don't jump to conclusions about which patients live where. So our business intelligence team have built an algorithm that takes a range of data sources to give us a guide as to who's less likely. And then we ask it as an assessment done on those individuals. And if they are from a non-Cornwall location, then we work on are we able to repatriate them to the local hospital, yes or no, clinically? And if clinically yes, then we have a whole process around achieving that. If patients need to stay here for their care, then they stay here for their care. We don't just move patients on up the country. I think it's quite important that I'm really clear of that fact. And I'll pause there and take questions, Mary.
Thank you very much, Robin, and point very clearly made. Thank you. Are there questions, Robin? Adam.
Thank you, Robin. 2 questions, please. On page 136 in our pack, the front page of the report, there's a section headed up consultation. That makes reference to the risk of not having a financial contingency pot. And I just wanted to understand what the risk is. Have we had a financial contingency pot in the past? What scale of financial contingency pot would we like to have? Or what have we managed to do to address that risk? And then it also says that we needed to check that renal services are able to manage dialysis of visitors should it be needed. I couldn't see that the report had covered whether or not we've been able to answer that issue. So if you could cover those 2 points, please, Robin.
Of course. Thank you, Adam. So what we're meaning by the financial pot, if you will, is if we see increased workload similar to that of winter, we end up with additional resourcing required. So we don't have a pot of money to draw down on, and what it results in is increasing our financial pressures. And we have to report those financial pressures as operational pressures in the reports that Ian is able to produce for us. So for at this moment in time where we remain under pressure with the additional workload we're seeing, we are still in our boarding and holding spaces, and they incur a cost as a result. But those spaces aren't funded. We've got additional locums right at the front door supporting the emergency department. Again, they're not funded, so they become cost pressures to us as an organisation. If we were in that place where we had a summer pot and a winter pot of money, then we would be making a drawdown on that. But that's, if we get my language right, they're not in our forecast, and therefore they are a cost pressure to us as an organisation, and that will come through in some of the finance update that Ian gives. In regards to we need to check that renal services are able to manage dialysis if visitors should need it. That's very much a case of patient by patient need. So some patients, they have mobile dialysis equipment they can bring on holiday with them, and they can manage themselves during their holiday. There are other patients that may visit who need to have access to us, and therefore we just keep a track on our ability to maintain capacity. I can tell all colleagues on this board at this point in time, we have no risks to our renal services at this time with any pressures. And it's just, I think it's there really, Adam, to note that it remains a risk to us, and we monitor it accordingly.
Okay, thank you.
Thank you very much. Richard Stevenson, I think I saw your hand go up. Is that right?
Yep, thank you very much, and thank you, Robin. Again, we've discussed this. I've had the chance to discuss this at Quality Assurance Committee. So operationally, I'm content and happy that it's in the right place. The question really is, a lot of this is predicated on population flow under the summer season, people moving in, some big events, etc. What's the communication plan that goes along with this to help do population management, help people know where to access services, when not to access services, etc.? Because these are people who would not normally be within the county in some instances.
Great question, Richard. So we've got really good links through the planning teams through to the ICB, and through the ICB communication mechanism, they liaise with the major tourist attractions, the major accommodation providers. We provide information that can go into the when you go into a hotel room and get a little booklet, we provide information they can put into those booklets and say this is how our house system works. We use targeted marketing through social media based on location. So your mobile phone knows that you're in Cornwall, so then our Facebook ads arrive on your phone saying that you can still contact your own GP. Your own GP can put a prescription that you can collect in Cornwall, and we take the time through those mechanisms to be advising people that if you need access, you can still ring your local and get and then still have your made available to you. And we also use that as an ability to explain to our visitors that our Cornwall solution is very heavily reliant on our colleagues in Cornwall Foundation Trust who run the MIUs, and that we encourage patients to attend those MIUs because that's our strategy of trying to keep patients away from our front door. So lots and lots of comms goes on. Sometimes, Richard, it even goes as far as the council put on the traffic information boards as well, information that as people are driving into county they can see, and that's all managed through one central route of the ICB, because it's not just RCHT feeding that. CFT have got elements to it, so have primary care and other parts of the health and social care system.
Thank you, Robin. Aled? You're on mute, Aled.
Sorry, just continuing that theme around the front door. Is there a field facility within? I'm just thinking of Boardmasters, 50,000+ people. Is there kind of triaging on site that avoids conveyance into? Yeah, I can see Alistair nodding, and opportunities to do broader messaging. Just thinking more kind of chronically in terms of strategy of RCHT and the system around things like sexual health safety, sun safety, etc. I mean, that kind of public health. I know it's not necessarily RCHT per se, but and the visitors are in rather than local population, but there's still always good opportunities to do that sort of thing. You're talking about mobile phones and messaging, just to maintain that, given that these things might not crop up for a few years' time, we should still keep an eye on them, I guess.
Absolutely, Alan. So that's part of the multi-agency review of large events to seek assurance that there is suitable on-site medical capability to manage. And I do know, but I wouldn't be able to list them all, but I do know that our ICB colleagues do attend some of these events and push those public health messages. I've attended some myself where I've been given free sun cream by colleagues. All of those actions all support that very message you're describing. But like I said, that's not so much us, but you do see it happening.
Okay, are there further questions on the summer seasonal plan? No? So thank you very much for that. Please could we endorse that plan and then move on to item 8.6 and 8.7, which I think are both yours, Kim. Care Quality Commission, Paediatric Audiology.
Super. I'll cover the first one. I'm going to take this as read. In fact, when it came on the agenda, I had to remind myself that this time last month I was about to go to the airport. How quickly time flies. So this report is noted as part of a national CQC and NHS England following feedback as regards concerns raised with children's audiology. Our initial response was submitted on the 28th of June. The deadline was the 30th. Our initial response went through ELT on the 15th of May, QAC, which is Quality Assurance Committee, on the 28th of June, and our private board on the 6th of June. This is a further follow-up as regards a little bit, shall I say, more meat on the bones as regards how we're going to reach our compliance, and will form the basis, working with the specialty within the care group, for our next submission. So for the members of the public, IQIPS accreditation for paediatric audiology is improving quality in physiological services, because there's lots of acronyms, even though we try not to. You can note that our referral to treatment compliance still is maintained for Q3, but working towards full accreditation mid-2025. And for those that remember, I have pointed out the reasons for that is we have to follow a full accreditation framework, which is, you know, lots of people will be doing this as well, and working with the care group, this is felt to be manageable. So this will form the basis of the update and our next submission according to our national requirements. And I'll leave it there.
Yeah, thank you very much indeed. And we are aware of this. Thank you for raising this before. Are there questions on this item? No, in which case could we note the current gap analysis and associations actions to be taken, and consider the assurance provided about the safety, quality and accessibility of children's hearing services. So if we could note those, and then Kim, ask you to go on to the inspection of urgent care.
Yes, so please note this is just further feedback as regards our initial quality care, quality CQC's feedback of our urgent and emergency, which is our ED department. Please, this has been through various committees, as you can see. We had our initial feedback in our Chief Executive's board report. This is just to note the immediate actions that have been taken, and to note that our improvement plan has already started with that engagement and will continue to do that. But noting in the current political climate, election, everyone voting today, we haven't received our formal report back, but the CQC did acknowledge that those would probably only come after the election period. So thank you.
Thank you very much, Kim. It's really heartening to see that we've already developed the plan ahead of the report. Are there other comments? Richard Crummer, people, members of the public can't see the chat, so you may want to make your point, and then I'll bring you in, Adam.
Yeah, sure thing. I just said that I don't think the CQC inspection has highlighted any new areas of concern that the board weren't already aware of. So I felt that we had a good understanding of the quality of the services and the challenges, particularly some of the workforce challenges.
That's really helpful. Thank you for saying that. Adam?
Thank you, Mary. Thank you, Kim. I apologise if I've missed it in the report, but the very helpful report in your presentation on page 195 flags the concern raised by the CQC about MRI scanning not being available between 7:30 p.m. and 7 a.m. I couldn't see how that's been addressed in the immediate actions, or could you talk through how we are planning to look at that issue, recognising resource constraints?
Yes, so that's part of the actions on the improvement plan. It's also part of some of the investment, because this is a service that isn't funded to do beyond the hours already listed, but it's part of some of the work that Alistair, Robin, myself and others are doing with the care groups as regards their planning for this coming year, noting what the request was and our ability to be able to fulfill that in the current restraints, but noting the quality and the safety of what's being requested, which is probably a long answer, Adam, but it's something we're picking up in the wider financial investment, quality, safety. What are we going to do to take forward, and how will that help in our flow programme as well?
Okay, thank you.
Thank you. Other comments on this one? Okay, thank you. We're asked to note the initial feedback and note the initial actions that have been taken, and that an improvement plan will be developed. So thank you for that, colleagues. The other items under 8 are all starred items, and I have not received any questions on those prior to the meeting. So I now have an ask of you. I was dangling the hope of coffee in front of your eyes, and we've gone on rather a lot. We could either break now, or we could see whether we can do our integrated performance report justice and then have a slightly later lunch break. I think that may be the better option. Yeah, nodding all round. Okay, thank you. Robin, can I ask you to take this report then, please?
Yeah, of course. Thank you, Mary. I'll take the report as read, as always, noting that it's a rather large report and has had significant scrutiny in FPC and the Finance Performance Committee and the Quality Assurance Committee. And a number of the elements in this report are picked up in Steve's update as well for colleagues. So I would really just draw colleagues' attention to the cancer standards. I know they're written in Steve's report as well, but the 28-day faster diagnosis, we achieved a 75% target. We achieved 75% against the target of 77. On the 31-day performance, we achieved 93% against the target of 96. And the 62-day target, we achieved 88% against the new lower target of 75%. And colleagues may remember in the annual planning, we committed that we would remain compliant with the targets and noted that their targets were reducing to that 62-day. Our diagnostic performance remains relatively strong at 83%. I think the important thing for colleagues to know is we are currently, as part of our elective recovery, really trying to work with our colleagues to have faster access to first outpatient appointment. That has the risk that it may reduce our diagnostic performance because it might create its theory of constraints. It will potentially create an additional demand into our diagnostic teams that they will then manage. So we're trying to balance improving that wait to first outpatient appointment without having a over detrimental impact on our diagnostic rates. But we have no concerns to escalate from a diagnostic perspective. I will draw the board's attention to that on the 104-week wait, we've not had any now for 2 months running. A 78-week position improved for 78 weeks improved to 65, and our 65-week wait, that's just 3 weeks, improved to 423. And we continue on our improvement trajectory towards the 78-week waiting patients and the 0 patients waiting over 65 weeks. We fundamentally remain as just a one single specialty issue from an elective waiting times perspective, the long waiters, which is our trauma orthopaedic team, and the team are micromanaging patients now to ensure that we get patients seen within that 78-week window, and then we'll be striving towards orthopaedics being to 0 for 65-week perspective. And then I know we talk a lot about the impact on our emergency department, and quite a lot of the conversation to date has been that. So I will just say that we have seen a deterioration in our non-elective, our emergency department performance, as Steve highlighted. We have therefore had, since the report was published, 2 meetings with our clinical leadership team, and really focusing on what are the actions that we want to harness all of the trust's energy towards trying to drive a different outcome in terms of that performance. And that's just finalising now into some time scales with actions and named people against them to make a change in the way our acute medical model works, and also make changes in the way that we flow patients through our hospital. And the intention of those changes, clinically led changes, is to mean that there's faster flow from the emergency department, which means that they're able to keep offloading ambulances, get patients out of our ED corridor as well, as that's a key objective for us. I will then do a quick whistle stop run round. Kim, is there anything you wanted to add from your perspective?
No, I think it's just important to note page 356. We did speak about this at QAC, but both RCHT and CFT, and we are not the only ones, remain non-compliant with the National Patient Safety Alert as regards bed rails assessment. Now we're only we've completed 4. The 3 we're non-compliant with. 1 we've almost solved, it's around policy. CFT is now complete. RCHT, we're just going through the final process before it goes online. The 2 that we've now had to fully second a physio to be able to do is there are 3,000 pieces of equipment out in the community. Not all people that have these will have come from CFT. Some are direct discharges from RCHT, and that is quite an extensive number to be able to go through. So we've risk assessed those. We're doing the most vulnerable adults and children first, and then we're working through. Our ICB colleagues are aware. We'll be talking about it both through our system quality meeting and our various QACs. And we've now got a robust plan that should be completed, finalised and done for the 1st of October. And so it's just being noted, but this has been more problematic and more extensive, I think, than doing the initial review within the confines of our buildings was simple. It's that wider spread, and how we maintain those checks so we don't grow any further is really important. So I wanted to be transparent on that part. And there is going to be a national task group as regards E. coli. There's a national growth in E. coli bacteremia, and there is going to be a national task and finish group which we will of course participate with, or look at what the implications of that is within RCHT and CFT. And I'll leave it there.
Thank you, Kim. Mary, did you want to ask your question before I go Alistair and Alison?
Yeah, I'll be very brief, Kim. It was only on the vast number of pieces of equipment. You said we're not the only ones non-compliant. Is there any learning nationally on how to manage this differently or better?
We'll be picking that up, I think. Yeah, absolutely, Mari.
Thank you, Robin.
Super, thank you. Alistair, anything you want to add?
I don't think so. I think we've talked through the mortality statistics in the Learning from Death paper. We've talked about stroke and fractured neck of femur, and you've talked about the pressures in ED in terms of their metrics. So I don't think I've got anything else to add at this moment. Thanks.
Thank you, Alistair. Should I jump to Alison and then take, or Isabel, is your question for Alistair?
No, it was for you, Rob, but I'm happy to wait till the end.
Should I do Alison and then we'll go around the questions? Alison, is there anything you want to add from the staff elements?
Yeah, I just wanted to point out in terms of the IPR that our journey in terms of retention and valuing our staff continues, and you can see that in the improvement in our turnover rate still, and vacancies have improved compared to we were in 23 and 24. However, we've touched upon it, I think, right at the start of the meeting. Actually, the live data that Kim and I have been looking at over the last month, if you add together the amount of staff that got COVID, cold, coughs or flus for June, it's 22%. And I still remain concerned around the amount of staff that we still have off on with stress and anxiety, as that normally features as one of our most prevalent reasons on why staff are off. However, you then look at the trend, we're going in the right direction, but we are going to see a spike in terms of also gastro problems this month, as well as those COVID, cold and coughs and flu. Thank you.
Thank you, Alison. Shall I hand back to you at that point, Mary, for questions?
I think Kim wants to come in.
Yeah, it's on exactly that. So there's got a joint communication I will share with board as well has gone out as regards what I would call just things to remember during this time, and advice on some of the questions that staff are asking about attending face-to-face meetings, for example, when to come to work, what to do. So we've just updated that and sent that out, and there is that common sense element as well. And for those that already, if you do have a vulnerability or you need to do a risk assessment, it's about making sure that you keep yourselves safe as well. We have had this discussion. Whilst we have got really good processes in place for bank and agency, we have seen that spike in requests because, as Alison has said, the 22% increase in respiratory and gastro. So we are keeping a close eye to make sure people that we're still safely staffed, but also manage the concern as we go through this time. We can also see the appropriate increase in COVID admissions to our services as well during this time, and making sure we're taking the universal infection control measures.
Timely comments, Kim. Thank you very much. And not to underestimate the point that you've made, Alison, about the staff off with stress and the extra stress that this puts on those staff who are at work. So it goes back to that thing about being kind to each other and looking after each other, doesn't it? And making sure that's happening throughout. Isabel.
Thank you. It was a question back to Rob regarding the deterioration in urgent and emergency care metrics, and I just wonder, to what extent do we know the impact of the opening and closing hours of MIUs on presentation at our emergency department? Because I'm aware that obviously the minor injury units are not 24/7, and facilities such as X-ray at minor injury units are not 24/7. So to what extent are we able to measure the impact of closure of MIUs in the evenings and the increased attendance at ED?
Thank you. It's a really good question, Isabel. We are finding it difficult to have a very clear business information map of MIU X shut 3 hours early, for instance, categorically resulted in these patients arriving at the Trelisk Emergency Department. We can't easily map if they went to another MIU or came to us. What we see is, if there is a number of MIU closures, we tend to see an increase in self-presenting patients in the emergency department, but that's not an easy direct correlation. That is definitely because the MIU was shut. Normally you can see a movement in those numbers, and part of that is some of the MIU closures are actually, they close not to the public, so a member of the public walking up to the unit would still go in and not know anything's changed. They change on the 111 system, and then the 111 colleagues know, but the population doesn't. So the 111 would say, actually, your next closest location is X, and they would just divert you to those locations rather than sending to ED. We have some anecdote of how much confidence people have in services if they're not sustainably running over a set number of hours, and that confidence can also be for our other healthcare professionals saying, actually, I will just refer you to, and that's very difficult then to map that through, because you've got a referral, you haven't got a first here and then diverted to there. So it's very anecdotal conversation to be saying the direct impact of the MIU closures, but as a whole system, and our ICB is very supportive of the need for us to sustain our MOU provision because our strategy is trying to keep people away from our front door. We actively work with our team in ED and our ambulance colleagues for, have you considered alternatives? These are the alternatives that are currently open. Are you able to stream away to them? Is a standard conversation that we have.
Thank you, Robin.
Thank you.
Alison.
Yeah, I was just going to comment on the MIU situation. I mean, we are lucky to have the quantity of MIUs that we have in Cornwall. However, I know from my visits that I did 2 weeks ago now to MIUs with my CFT hat on, that actually, as Rob says, it's a really complicated system, because when I did those visits, what I was picking up was primary care was under pressure, and therefore patients were being referred direct into MIUs on things that, you know, perhaps should be sat with our GP colleagues. So it is a really complicated picture about how you push one lever and then the impact of where it lands.
Ellen?
Yeah, thank you. I just thought it might be worth adding, so as a system, we have stated one of our priorities for the next year, 18 months, is to look at the urgent emergency care 24/7 offer for the whole of Cornwall and making sure we've got that right. So there is now a working group, there's a whole system working group looking at that and looking at what the strategy should be. So I think board can expect to see some outputs from that in the not too distant future around what hopefully, you know, that enhanced and better offer 24/7 looks like for the whole system.
That sounds good, Ella. Thank you. Really helpful to know that. All right, colleagues, have you got any other thoughts or comments on the integrated performance report? In which case, could we just note that and note having discussed it. So it is 12:05. Would colleagues be okay if we took a 25-minute lunch break, not a 30-minute lunch break, and came back at 12:30? Can we have some nods or some violent disapprovals? I've got some nods. Okay, thank you very much. We'll reconvene at 12:30. Thank you. Okay. Welcome back, everybody. Thank you for taking a slightly brief lunch break. And we've still a bit of work to do. So could we then come to item 10, which is our Finance and Performance Committee Assurance Report. And I know this committee also has some matters to escalate, which we will discuss. But if I could invite Richard Stevenson, please, to introduce your report.
Thank you, Chair, and thank you, colleagues. I'll try and be brief in the interests of time and just remind colleagues that this report that you have before you covers both May and June meetings of the Finance and Performance Committee. As always, I'd ask the board to note any decisions that have been taken by Finance and Performance Committee on behalf of the board through its delegated powers, and also to note those items that are recommended to the board for decision that will appear on and have appeared on the June agenda and appear on some of the July agendas today. In terms of items to escalate, you'll see a few examples in the report, really around just the articulation and some of the clunkiness that still exists with our system architecture of governance and operation. And I think our escalation really for the board is to ask the board to give some consideration to how we can further work closely with our system colleagues and further work to develop that architecture so that it's more seamless and information flows more freely. Perhaps the ask is that our board members on the ICB and the Integrated Care Board perhaps reflect some of those areas of challenge and offer our support as to how we might make that more smooth. The second area of escalation I think that we want to bring to your attention is, as the board, is one of awareness rather than action. And it's just to note that the run rate, by that I mean how much more we are spending currently against our plan in the month 1 and month 2 reports. We've got the month 2 report, which Ian will introduce in a moment or two. But our revenue is progressing faster than our plan, and we have to look at how we address that. The report also identifies the grip and control mechanisms that are being employed, and I think that's really important for the board to take cognizance of those, of the work that's already undertaken, and it's brought some of that run rate down in month 2 from where it was in month 1. But our recommendation is to be aware of that, and perhaps for the end of month 3, when our picture becomes a little bit clearer, which will be the end of the first quarter, that the board might want to pause and just reflect on our performance against the plan, on those grip and control measures, and think about whether there is anything else we need to do to ensure that we have an appropriate recovery period over the rest of the year. I'd ask also from the report just the board to note those areas of partial assurance within the paper. I hope that the reasoning is clear, and a number of those items appear on different agendas anyway, but we'd be very happy to take questions around any of those areas of partial assurance. And then finally, just draw the board's attention perhaps to a number of items that have been moving through Finance and Performance Committee that are there to enhance our strategic ambition and our operational performance. And so when we're faced with some of the challenges and the risks around our financial and performance plan, just do pause and note things like the research centre, the St Austell development, the microbiology expansion, our capital projects overall, including the Women and Children's Hospital, all of which are and will directly benefit the population and care of the population of the people of Cornwall and the Isles of Scilly. So there's a real lot of positive stuff embedded within that report, as well as some of the areas of challenge on assurance. Happy to leave it there, Chair. Take questions.
Thank you very much indeed, Richard. And I'm glad you have mentioned the areas that are positive, because quite rightly the board does need to focus on what we can do about the things that are going a bit adrift. But it is welcome and to be strongly commended how much other work is going on to ensure that we go on developing as a trust. So that's really good to see. I think I may have a couple of points, but our colleagues, are there points that anybody would like to raise with Richard before coming on to Ian's report? No, must be a very comprehensive report, Richard. Thank you. So I absolutely note the escalation regarding the system recovery programme, and I think Steve and I can both bring that up in the appropriate way. I guess one of the things I wanted to celebrate and then say, how could we do better? The cancer standard combined performance is really great, isn't it? 28 out of 148, which is super. I'm just wondering, and maybe Alistair could help me here. So if we can be so good, what can we do to be 1 out of 148? What else? How else could we develop our brilliance in this? Because it is super.
Do you want me to come back on that, Mary? So that's a really good question. So I think part of this, I think, speaks to our ambition to be a university hospital, and working with our university partners to develop the extensive research portfolio that we already have into other areas, and to develop a unique selling point, if you like, for Cornwall in terms of research. And we've had lots of really good conversations with the University of Exeter's team around how we might work across Cornwall and the Isles of Scilly to look at things like our coastal and rural communities and how we might bring in primary care and community research into that sort of portfolio, but then also expanding jointly with Exeter, with Plymouth and with Falmouth, our research portfolio. I think part of our drive to develop that university status is to have more of our clinicians with dedicated research and university time in their job plans. So I think all of that benefits our patients, it benefits our staff, and it benefits the organisation. So I think that continued work is absolutely key. I'm sure that other colleagues would want to come in on that, maybe Ella or Kim as well.
Alistair. Ella, did you want to come in on that point before I bring Robin in?
Yeah, so I'd agree with what Alistair said. I was going to add something else. If Robin wants to go first, that's fine. He may cover what I was going to say, and it's fair to go in order.
Okay, thanks.
Robin. Yeah, I probably am going to sound like Ella for a moment. So there's two things for me, Mary, and answer your question. One is we've got the Cancer Delivery Board we've spoken about previously, and that's our day-to-day functional drive for improvement. But actually, Ella and I are joined up at the moment having conversations about how between our two portfolios we create an environment to have a 5-10 year elective strategy plan utilising Gary Matthews, who's the Associate Medical Director for Planned Care. And those are 5 and 10 year plans for cancer and electives, and starting having the conversations about how do we tie in our ambitions for research, our ambitions for universal hospital status, our ambitions around using digital in a different way, and just what the future will really look like. And I think that those two things are the spaces for how we get our ambition moving for being the top, on the top step in the country. On both electives and cancer, in all honesty.
Yeah, because we can, we've got, this is such a good indicator. So thank you for that. Ella, did you want to add anything at all?
So Robin did cover a lot of what I was going to say. I think just important to emphasise, I think there is a real opportunity for us in cancer and oncology, because when you triangulate those things around our expertise in research, some of the excellent individuals and staff that we have already, and our historically strong performance in this area, I think it is an area where as a board we should be showing real ambition, and as Robin describes, we intend to take that forward.
Yeah, thank you, Ella. Other points? Because I've got other questions if others haven't. No. Steve, maybe you could help me pick up the other escalation point around gaining assurance about the system risk mitigation around the St Austell site. I understand that the executive group has had some conversations about that.
Yeah, very happy to do that. So as a system, we've agreed the first 12 months use of the St Austell elective surgical hub site, which I think is set out in the board papers, a mix of general surgical use and orthopedic use. Surgical teams are preparing on that basis. Recruitment's underway, and we expect that to commence towards the end of summer, early autumn. So all of that's been agreed, not just with the ICB, but with NHS England as our regulators as well. There'll be a review after 6 months to then give consideration to any learning from that process, and any changes that would then entail to future case mix. So we'd have to come back to the board at a point in the future with regard to that. There is a lessons learned process underway that RCHT and the ICB have agreed in terms of the extended timeline and the challenges associated with finalising and agreeing the case mix use of that facility. And that might, as a lessons learned process, also help address or give a different perspective on the escalation, the first escalation that Richard raised in terms of system architecture and kind of infrastructure mechanisms. The learnings from that might help us with some of those broader aspects as well. I'm not sure if Ella would want to add anything to that from the elective surgical hub perspective.
I don't think so really, Steve. Just I suppose that assurance that we are mobilising as rapidly as we can with that, and the teams are trying to pin down an exact start date for us within the next 2 weeks, so that within 2 weeks we'll know when that future date will be, rather than we'll be starting in 2 weeks. Sorry if that sounds a bit convoluted. So that will be a really important marker for us, and once we've got that, we obviously need to be putting all efforts in to go live.
That's really great, thank you. And we said we're going to develop a letter with the ICB with regard to system risk mitigation. So is that part of that process, Ella or Steve? Ella.
Yeah, I could come in on that one. So we discussed at FPC, because we saw the business case for St Austell, which is going to board in private later today, that there are, as we mobilise this, still some inherent risks within it, as there are for any service run really. But I think it was, the point there was around us as an organisation wanting to continue in the way we are currently, in that this is a shared project and therefore shared risk and shared mitigations across the system with our partners in CFT and the ICB. And I think just the point we were making through, and it went through our Finance and Performance Committee, was that we would want to be seeking that kind of shared approach going forward. And I believe that is everyone's intention. We just want to be really clear on that.
That's really helpful, thank you. So, Richard, in terms of the escalations and information to the board, we can take forward the project evaluation, post-project evaluation of the system recovery programme. But in terms of your points about the cost improvement programme and around needing greater oversight of cross-cutting schemes, how would you like that to be taken forward? Steve.
Well, perhaps just before we come to Richard, to update that as a system, chief execs and executive colleagues from ICB, RCHT and CFT are meeting early next week to review the Q1 position at a system level that Richard's just described, and identify any further actions, escalations or other mitigations that can be taken to manage the financial position at a system level. And of course, RCHT is a key part of that system as well. So it might be useful, Richard, for outcomes from that to be fed back to the future or to the next Finance and Performance Committee. Mindful that that might provide some opportunity for further clarification and lessons coming out of the system recovery plan from last year, and provide some further framing for the escalation and control mechanisms at a system level for this year as well.
Richard, do you want to come back on that?
Yeah, I think that would be very, very helpful. I think the main point that, as it's the pinch point as it's felt for Finance and Performance Committee, is in the absence of some of that key information flow, which currently exists, i.e. the absence currently exists, there are mechanisms in place that are seeking to address that, but it's very difficult in the vacuum of some of that information for F&PC to make its right decisions about risk, resource allocation and understand the impact on the plan. So I think the work that Steve's taking forward with his executive colleagues should bring that to a resolution. But it's really just raising awareness at the Integrated Care Board that poses some challenges for individual organisations, and how we work together very closely to address that.
Isabel?
Yeah, thank you, and I welcome Steve's sharing with us the plan around that meeting. And I just wonder if it's going to be also an opportunity to think more broadly about the system architecture and how that relates to us as a sovereign organisation, whether part of that conversation might venture into the territory of the quality agenda as well, in which case, if there are lessons to be learnt from that meeting, whether it could be shared back to all our committees as appropriate. Thank you.
Yeah, thank you, Isabel. That's helpful. And I had the opportunity this week to be talking to the lead for ICBs, the national lead for ICBs, and it was a really interesting conversation around how the national expectation is that ICBs will just get on and solve their problems, but by doing very much what we're doing already in terms of working closely together. So I think that requirement to work collectively is very clear. Steve.
Yeah, really helpful suggestion from Isabel. I think it complements the question and challenge from Richard as well. So I'm supportive of that. In just reflecting on the meeting that we've got scheduled for next week, I'm envisaging that meeting with system partners would put us in a position where we could likely have a common report that would come back to the ICB board, to RCHT board and CFT board. I think primarily focused on in-year recovery, but I think would be an opportunity to pick up some of those broader aspects that have been covered as well. So I don't want to commit my system partners to that course of action, but I think it would be kind of a reasonable expectation to say there is an absolute interdependency between the three NHS organisations in Cornwall and Isles of Scilly in terms of financial delivery and quality and performance delivery. So to expect a formal report to come out covering the risks, actions, options and next steps in terms of the financial recovery, which I think would include the opportunity to get into some of the broader aspects that Richard and Isabel have discussed. But if I could just test Ian's view on that as well, if that's okay.
Thanks, Steve. Ian?
Yeah, absolutely agree with that, Steve. And I think it's also important we have the context as a board in terms of where our system partners are and the opportunities and risks that exist within those system partners, as well as our own, which we're more familiar with. So yeah, I'm more than happy as part of the normal process through our finance performance committee and then to next month's trust board to make sure that we reflect on the meeting next week and the kind of actions and risks, etc., that arise out of that.
Thank you, Ian. Steve?
And just to add to that for completes, that's really helpful, Ian. I think that would need to include a summary of the cost improvement programme from an RCHT perspective, and also the cost improvement programme at a system level, so that we have that assurance and clarity within our organisation and across the system, and also clear on risks that are associated with that. So that's something that Ella can continue to lead on with all of us supporting and form part of that report, I think, back to our board. And I'd expect a similar sort of system-wide approach from a cost improvement programme perspective as part of that financial recovery as well.
I think that would be very helpful, Steve, for our board, because we are interdependent with our partners on achieving this, so that would be really, really helpful. Okay, are there other questions for Richard? So Richard, do you feel that we have addressed your escalation and information matters sufficiently?
Yeah, absolutely, and I think it'll depend on what we get back from that meeting, but that seems to be the right mechanism and seems to be the right level of expectation. And in terms of the other escalation around looking at things in month 3, I think that's just for the next board consideration. And
the next board.
Yeah.
As Ian has indicated. Okay, thank you very much. In which case, let's note that report from the May and June Finance Performance Committee and move on, Ian, please, to your month 2 revenue finance report.
Yeah, thank you, Chair. So in the normal style, I'll take the report as read, and I'm going to just try and cover off under a few key headings the position as we find it at the end of month 2. So at the end of month 2, we're 1.3 million adverse to the plan that we set. So that's a slowing of the overspend that we saw when we had at month 1, which was £1 million adverse. But as we've already touched on in Richard's report there, our run rate of expenditure, so the amount of expenditure we've got is still too high compared to our income position. So what's going well from the report? Our agency spend reduced significantly in months, so it came down from 1.8 million to 1.4 million. And that was predominantly in nursing and HCA agency usage. We do, though, need to see more traction on our medical agency, and we've already touched on some of the challenges in terms of medical recruitment and gaps. The other thing that's going well is our performance against the elective recovery variable income continues to be strong. So based on the latest published data, which is up to February of last year, that's running higher than we'd previously modelled at 1.1 million, and that's reflected in the month 2 position as well. What should we be worried about as a board? We still have a significant deficit overall, so our deficit at month 2 is £2.1 million, and that compares to our planned deficit of £800,000 at this point. The adverse variance that we've got to plan is focused in our care groups, and predominantly, so our care groups on in aggregate are 2.6% overspent year to date, and that's equivalent to £2 million. The other things we need to be worried about are our cash position. So our cash position has deteriorated since the beginning of the year, and our cash balance at the end of May, as is in the report, was 6.4 million. There's been quite a lot of work done with system colleagues in terms of raising the awareness of this and setting in train the steps that we need to take to mitigate that. And a fuller report was considered by the Finance and Performance Committee exceptionally at month 2, and we'll have the regular quarterly report on cash at month 3. And I'm pleased to report at the end of June our cash position remains at £6.4 million, so we haven't seen a further deterioration since the end of May. The other thing we should be concerned about is the operational impacts from both the IT outage that Steve referenced in his chief exec's report, and also the commencement and conclusion now of the 5 days of junior doctor industrial action that took place from the 27th of June. And the reason that's something we should be concerned about is that that has an additional cost for us to deliver care to patients during that period, with additional payments to consultant and other staff colleagues to cover those gaps. In previous financial years, there has been some support funding nationally to cover that cost, but at the moment, we're not being given any indication that there will be further support to that. And on a normal 5-day from previous financial year, a 5-day strike has a cost of in the region of £1 million for us as an organisation. So a significant material number that we need to be mindful of. So then, just coming on to what actions we're taking and what support we need, we're focusing on the both the brought forward recurrent SIP transactions and also the in-year SIP delivery. And my team, along with Ella's team, have worked to share the details of vacancies over the last 2 years to help support those conversations and make sure we're focusing in the right areas. We're updating our income position for the month 3 report to assess how we think we're doing against the variable income across April and May. There are meetings that I'm having with my deputy, with those care groups that are off plan, to understand some of the key drivers that are underneath the monthly expenditure rate that we're seeing. There are then weekly cash meetings and the additional deep dive report that I mentioned that's been to the Finance and Performance Committee, and that will come forward in more details to Finance Committee and Board next month. And then we're requesting, and we're now at the stage in the year where we will be doing forecasts by each of our care group and corporate areas. So that's a forecast of what our income and expenditure will look like for the remainder of the financial year. And it's really important we do this early in the year so that we can see what the potential risk is to our financial position and then what mitigations we can take as part of that. So our care groups have been asked to complete those next week, along with recovery plans, and we will then monitor that through our performance review meeting structure so that we can be clear both with care groups and with our committees and board when we will expect to see those improvements in our overall trajectory and be comfortable that we're making the progress we need to make, or identify if we need further actions to address. So they were just some of the key things that I wanted to summarise in a slightly different way than normal, but hopefully that's helpful. But happy to take any questions on anything I've said or the content of the report.
I think that was really helpful, Ian. Thank you. Really well structured. Very helpful. Colleagues, are there questions for Ian? Robin?
Not a question for Ian. It's to show the join up across our portfolios. So as Ian's described, there's a lot of focus on our income potential. So one of the things that we do through the elective recovery programme is really focusing on that utilisation of our theatres, how we reduce unwanted variation for access to those theatres, because the more we use existing resources, the more throughput we get without increasing our cost base, the more that drives our overall productivity, gets more patients treated, which is a good thing, and at the same time it supports our financial position. So we're really trying to join up that actually doing the right things in the right places delivers our plan. And Ella gave us, again, this join up that we do. Ella, you had a great phrase of us, the plan is to deliver the plan. So we're really trying to say to our teams, focus on the plans that we put in place, focus on what needs to happen to deliver those plans, because it then links through. So early days was, I think, trying to be in that smarter working, but I think it's showing some early fruit for us across those challenges that we've got.
Thank you, Robin. That's really helpful. Are there other points for Ian? Don't think so, Ian. I think you've done too good a job for us there. So we're asked to note the month 2 finance position, which is adverse to plan, driven by pay overspends and actions, and the actions outlined to address this, to note the updates in relation to the final plan resubmission required and completed on the 12th of June, and to note the risks, including the additional risk relating to known industrial action taking place at the end of June. So if we could note that and ask Ian then kindly to move on to month 2 capital report, please.
Yep, thank you again, Chair. So this one is going to be a bit quicker. So this is the month 2 capital report. It's now been updated to reflect the board agreed final capital plan that we considered and approved on the 6th of June. Overall, we're just over £500,000 behind the plan at month 2. At this stage in the year, there's no significant concerns in that. The paper outlines the reasons for the differences to the plan, but there's nothing material at this stage that I want to bring to the attention of board colleagues. The one item it's worth pulling out of the report is that as a result of submitting a break-even plan as an organisation and as a system, the system has been allocated 7.1 million of capital incentive funding, so a really significant amount of funding. Work's been ongoing over the last week or two and is expected to culminate probably in the middle part of next week on how that will be allocated and how the system can use that to best effect in terms of our appropriate capital requirements and risks across the system. So we're considering several options on that, and as I say, we'll bring more detail to the next finance committee and to the next trust board. But for example, that might include whether we can look to incentivise care groups in some of our where we might have lower risk capital items, so items that wouldn't reach the threshold for our prioritisation in the main capital programme, but where they might unlock benefit, and how that might then support our revenue position and other aspects. It's worth noting at this point that additional capital funding isn't being cash backed. What that means is that there isn't being cash given to us to support that. We're making quite strong representations with our regional NHS England colleagues as to the fact that will be challenging for us given our cash position, and clearly in delivering a challenging revenue position, spending additional money on capital without the cash resource to supplement that is nigh on impossible. So we've made that really clear, and we continue to work really collaboratively with our regional colleagues and their support in terms of managing that message with the national team as well to see what can be achieved on that. But let's not lose fact, that's a really positive thing that the system has been rewarded with that capital incentive funding. So as I said, there'll be more details to follow on that, but wanted to make board members aware of that update, and happy to take questions.
Thank you, Ian. Thank you very much. Questions for Ian? No, I think it's probably all very clear, Ian, so thank you. We're asked to note the position for the period to the 30th of November, and that we expect to operate within the capital departmental expenditure limit budget this year, and to note the confirmation of national capital incentive funding and further detail of this. And we also note the proposed options to allocate as a system will be included in a report going to the July Finance Performance Committee. So if we could note that, please. Thank you very much, Ian and Richard. That brings us on to the People and Culture Committee report, where I'm going to invite you, Adam, to share your report with us. Thank you.
Thank you, Mary. And obviously you've got the report in front of you. I will just highlight a few items for our attention now, and then very happy to take questions. One item from our May meeting that we wanted to escalate to the board, which chimes nicely with some of the previous discussions. The lack of a system-wide strategic medium-term workforce plan, and absolutely recognising that RCHT needs to contribute to that and work as effectively as we can with our partners in CFT and the ICB to make that happen. And you'll probably ask me, Mary, how do I think we're going to do that? And it's I guess the critical challenge here is probably carving out the time to focus on the medium term for ourselves and with our colleagues, which we all recognise is extremely difficult to do with all the challenges we've got today. But that feels like the critical thing that we need to do. So we're flagging for our attention that we don't currently have a strategic medium-term workforce plan for ourselves or for the wider system. There are 2 items that we are recommending to the board for approval, one of which is on our agenda today as item 11.1 is the equality objectives, which we agreed at the May People and Culture Committee. The other item, the Workforce Equality Standards Report, will actually come to our September board meeting as part of a package of human resources related papers, people related papers. And then to highlight a number of items in the body of the report, particularly focusing on items where we felt able to only take partial assurance, of which there are a number. So we absolutely recognise there's an awful lot of good work underway across the Trust, and we've talked about this in some of our earlier items around the IPR, and there's some really promising signs of improvement in some of our key people performance measures. But we still haven't got our people performance measures where we would like them as a Trust. So we have flagged the IPR as an area where we're taking partial assurance because of what I've just said. Linked to that, health and well-being. There's an awful lot of good work going on around health and well-being, but we're really keen to see how we can demonstrate the direct impact from all of that good work that we're doing and how that's starting to reflect in the integrated performance report. We've talked already around the workforce efficiencies programme, and that's just been mentioned in the finance reports. And the challenge there, we didn't feel able to take full assurance from that, whilst recognising there's an awful lot of really good work going on between RCHT and CFT in particular. Again, really good work going on around the OD, the organisational development implementation plan. And we're really pleased with the progress, but again, didn't feel quite able to take full assurance at this stage, and particularly wanted again to see how we can demonstrate that's making a difference across the organisation, linked with branding, messaging, communications across the organisation. Really starting to see that making a difference. And around the workforce equality standard and around the board diversity plan, a particular area we wanted to see and understand better was around the staff networks which have been established, and starting to understand better how they're starting to work and what difference they're starting to make. And we're looking at how we can understand that better through the People and Culture Committee. And I will stop there. Happy to take any questions.
Very much, Adam. I think there's a number of reports to follow where there might be some questions, but people do have general questions for Adam. In terms of the the lack of a system strategic medium-term workforce plan, we can raise that in terms of what would be a timescale that we could be looking to for that. Happy to raise that at the ICB. Ian?
Yeah, more just a comment or an observation, Chair, but I agree with that, Adam. It's helpful to see it coming through this route in terms of the alignment of a medium-term workforce plan with our medium-term financial plan as well. So we've been doing that for kind of probably a couple of years now in terms of the medium-term financial plan. But given, as we touched on earlier, particularly some of our challenges like in medical workforce, what are our options around that, and how do we start to plan for the future? All of the stuff we've already described earlier in our board meeting today, but I think that's really important. I'd really welcome us joining that together with the financial plan as we do the medium-term view on things in the way you've described.
Thank you.
Isabel, then Steve.
Yeah, thank you. Just building on Ian's comment, actually, it would be really helpful in that medium-term workforce plan to get a much stronger understanding and assurance around the likely change in roles. So when we're talking about transforming our workforce, what are we talking about? What are we changing from and to? Which would include the introduction of new roles as well. So if we can have more information around that, that would be really, really good.
I'll bring you in a minute, Isabel. Steve.
Yeah, that certainly support the challenge of a 5-year medium-term workforce plan. I think it would fit very well with developing our overarching strategy across the system. What does that look like in terms of what colleagues term channel shift, moving care closer to home wherever that's possible? What that looks like from a budgetary expectation and what that looks like from a workforce expectations. So very much support that. As a priority, initially with system colleagues, we've agreed to bring forward the planning timeline for the next financial year so that commences now, 6 months ahead of perhaps where that would normally be. So what we might need to progress as a order of priority, Adam, is making further progress on what the workforce outlook for the next 12 months looks like, whilst that longer term 5-year workforce strategy is developed. I think that would fit well with the work that's underway looking at the development of next year's plan. But I don't think that in any way undermines the importance of what you're describing, which I agree with, that 5-year workforce strategy.
Thank you. Kim?
So I think this is where it's important that we don't lose shape and form, isn't it? So the bulk of RCHT as well as CFT's cost efficiencies are all built into the workforce efficiency programs, and I'm sure Alison will come onto that. So we've got to have that triangulation, haven't we, of where are we folding in, where are we moving resources in line with the clinical model end-to-end pathways, what is the savings that fall out of that, and most importantly, you know, what finance does that release, or how does it inform where we're going to have to invest? The narrative around here is really important for our staff. That if we're not careful, there will be a perception that we're trying to find a cheaper workforce to do the roles, as opposed to advancing skills, practices, career framework. And I cannot understate or overstate that, because that is a concern that we're starting to hear. So as we need to be clear on what we're advancing practice, giving career frameworks, doing those end-to-end pathways, the cost efficiencies in that, and most importantly, the value of that for culture, staff health and well-being, and all of those, or we will start to muddy the water and cause antibodies, is what I'm saying.
Yeah, agreed. And that needs to be one message across the whole as well. Alison.
Sometimes you could just give Kim a hug, couldn't you, really? She's just said exactly what I wanted to say, but probably better articulated. So the only other comment that I would say is please be assured, in terms of, we've been really pushing for the Workforce Committee for where is the system workforce plan to map into the clinical strategy. But as you know, the clinical strategy has been chicken and egg. So I couldn't agree more. And and there are some real sensitivities around those changing roles. Nationally, it's a little bit playing out in RCHT, but not as much as the concern that is raised nationally.
Thank you. I agree with giving Kim a hug. Isabel.
I think we'd all want to do that. I think general consensus, we can all sign up to hugging Kim. I think the point I was going to make was just based on, again, the earlier conversations we were having around transformation of services and using diabetes as the example, which was discussed in some detail at the system committee. You know, there's a lot of talk around this term channel shift. And so if we're talking about channel shift, what does that actually mean in terms of resource shift from providers to third sector, social care organisations, and where's the opportunity in that? So picking up the point, the really important point Kim's made around the narrative and the communication, this can't be seen as a cost-cutting exercise. It's got to be seen within the context of providing the right services for our population. And how do we make new posts, as a consequence of channel shift, for want of a better phrase, how do we make those really appealing with career progression built into the offer? So I think, you know, there's a huge amount to think about in terms of developing a medium-term workforce plan.
Which we're not going to solve here, but for those of us who are involved in it, you can hear the sense of concern and need for pace, really. So one of my questions was around how effective are our comms with staff being, which I think to an extent, Kim, you've already touched on. But I think we do need to keep that pulse going and check where we are with it. Really important. I did have a slightly separate point around sexual safety, which I know we endorsed that policy principle a few meetings ago. Have we yet begun on an action plan for that, or when might we do that? Alison, are you able to help? Thank you.
Yes, so as you say, we endorsed that at the board a few meetings ago. It's incorporated with our main staff survey plan and corporate actions, and the paper's going well to the very next People and Culture Committee, which will give an update on what we're doing and how the actions are progressing. So that's within, it's a paper that's already written on its way to PCC.
Super, thank you very much. So before we move on to the equality objectives,
sorry, Maury, that's okay. You might not have seen my hand, that's okay. So Alison, we might just need to team up, because Jasmine Godwin, who's our domestic abuse coordinator, has done a paper to go to QAC against so I think we just might need to join up and have one integrated paper, but we'll pick that up.
Yes, so the paper that's going to PCC is staff survey, and it picks up on the elements of this. So, but we'll do that cross-check, Quinn.
Thank you very much, both. So we're going to note Adam's report from the People and Culture Committee, and move on, Alison, if I could, to the equality objectives, please.
Yes, so this paper, most of you, noting that we do have a new non-exec director amongst our midst, you will have seen before. And during the process of consultation, it became apparent that we weren't very comfortable with the wording in objective number 4. So it's been through another process, predominantly through the work that was carried out during the Equality Conference, but then back through all parties within the ICB to approve the equality objectives. And so you can see within objective number 4, there is a slight new wording. So we're the last now to sign this paper off, and then we will have agreed equality objectives across the system. Thank you.
Thank you very much. Questions for Alison? I guess my only question was around when we're going to start the implementation of that.
Yeah, and as I say, a bit like my previous answer on the other staff survey, so we have got work in train, just because we've been sort of wordsmithing the equality objectives doesn't mean to say that it hasn't been work going on. And in fact, there is going to be a paper to People and Culture Committee, which will explain our progress against the objectives and the wider work. We also submitted, Chair, for your information, a presentation to the Workforce Committee on both trusts in terms of our approaches to equality, diversity and inclusion, and the progress that we were making as well for the June committee.
Thank you very much. That's great. I've got Richard S, Steve, Isabel and Richard K.
Thank you for the paper. I'm a bit torn because I realise that the consultation has brought us to the point of where those objectives in the blue column now sit, and I fully applaud that. I think that's brilliant that they're owned. They read a little bit more like pledges to me than objectives, in the sense of I find it difficult to think how we would measure those. They don't come with a timescale. So I guess the paper talks about then that we'll have smart actions that tell us how we'll deliver to those. So I guess the question is a bit like Mary's really. When will we see those smart actions? And will we get to have some input into the pace and scale and the deliverability of those? Because at the moment I would find it hard to hold ourselves accountable to the objectives as they're currently written.
Would you like me to respond now, or,
yes,
or take all? Okay, so
why don't Alison, why don't we take all four and you make a note and we'll respond. Thank you.
Okay, thank you.
Richard, thank you very much. Steve.
Yeah, I welcome the paper, and I think it's very helpful, Alison, to see the edited amendments that reflect the comments that board members have previously made. So I think that's very positive. I was going to comment on the question that Richard has raised, Mary. All executive directors have a equality, diversity and inclusion target, which is being developed in parallel to the organisational level and system level objectives to try to enable mechanisms for that progression on measurable smart actions that have just been asked. So that whilst that's being developed in parallel to this work that's underway, I think in most instances those executive director appraisal objectives for this year do reflect the overarching system targets, and that they, I think, Alison, would form part of how we could then evidence progress against those areas. That those individual targets have more specific expectations and measurable aspects. So it's possible for us to think about how we would report back at an organisational level against the objectives and against those individual steps that are underway as well.
Thank you, Steve. And actually, non-exec directors will also have those targets within their annual targets, which I think we've touched a little bit upon, but it may be interesting to just publish some so that people can see, and we can talk about that further. I think Isabel and then Richard K.
Thank you, Mary. I really welcome the paper and welcome the edits to some of the wording around it. I think in terms of the fourth item, which obviously links to my agenda with quality and safety, particularly, although I'm sure all of them do, I was wondering again how we monitor how we're doing and how we ensure that certainly within our committee structure that we're picking these items up. So I would, for example, want to see that we are demonstrating patient involvement in the papers that we're looking at through the Quality Assurance Committee in the Part 2. You know, and so are we in a position where we can commit to doing that at this point? Because I know, you know, we're lucky we've got some very good patient leader involvement in various programs, but in terms of our overall quality agenda, we're going to have to find ways to have smart actions that actually ensure that we're delivering against that. So there'll be a committee responsibility, I guess, as part of this in terms of the overseeing and scrutiny in relation to this, which naturally might necessarily have sat within People and Culture Committee, but actually needs to sit within all our committees.
Thank you, Isabel. Richard.
Yeah, I think all the points have been made that I wanted to make in terms of being incorporated into our action plan, and seeing the follow-up in the action plan, our work to be incorporated in all the committees. I was the new Ned, and I don't want to be a late wordsmither. So, what I do want to say is that as a new Ned, that the wording is a real improvement. It's really good. It is more visionary, stronger, inclusive. I like the way it starts with we, as it means the whole trust and every level of the trust. And it's about our strategy, culture, and leadership at every level. So I very much welcome it.
Thank you. Alison, would you like to come back on those points?
Yeah, so thank you everybody for your feedback and comments, and absolutely the People and Culture Committee will be there to monitor and scrutinise our progress. I think the most difficult bit for myself and for the team, and Lindsay, I know appreciates this because I've had many conversations with Lindsay about it, is that we have an obligation to report not only on these objectives, but also to the Equality Delivery System 2, which is a statutory duty. And that's where, particularly Isabel, where the patient voice is really important. And we reported on that for the first time last year in full. The previous year was in partial. So you also note within the table, it talks about the high impact actions as well. So actually the difficulty that I have is reporting through all of those action plans and for you to see how it all comes together. And we plan to do that at the next, hopefully, the next People and Culture Committee. It might be worthwhile recirculating our previous submission that we did under EDS, because then you'll have the action plan that we're also monitoring within that as well.
I think that would be helpful, Alison. Thank you very much. Okay, so what we're doing with the equality objectives, we're going to approve the trust equality objectives, if you would note your approval. And then I'm going to invite Lindsay to do the board diversity plan. And could I remind us, we are running slightly embarrassingly late at the moment. So we're having some great discussion, so I don't want to close it down, but if we just go on being succinct. Thank you. Lindsay.
Thank you, Mary. I'll be as quick as possible. Presented is the board diversity plan. The plan was actually approved in September last year, and the People and Culture Committee received a quarterly assurance report on progress on the action plan, and it was last presented to committee in May. There are 6 actions set out in the 23-24 plan. The board is actually asked today to approve the closure of 2 of those actions and note the extension of the remaining 4. So we're proposing the closure of action 1, which relates to the next director scheme for aspiring non-exec directors for underrepresented groups, and we as a host have put a placement in place. We have a placement which and Uzma Bozai joined us earlier this year, which is absolutely fantastic. We're also recommending the closure of action 2, which relates to the race equality code review, which has now been embedded into the EDI action plan, so therefore it's proposed that we close this. I think it's important to reflect that we haven't actually made as much progress as we wanted to do with the remaining 4 actions, but we continue to aim to close these at the end of this month, and I will work with our dual chief people officer Alison and our associate director of EDI to progress them. We will shortly be issuing a supportive statement in response to Action 3 regarding our EDI sections on ESR. Alice and I have spoken about that recently, and that's really just to encourage our board colleagues and our senior leadership team to complete these sections with this important information. And board members will note that as outlined in the action plan, we have a EDI session planned for later this year. The People and Culture Committee in September will receive July, not September. July will receive a proposal around the closure of this plan, noting that there might be some actions that need to be deferred, and this will be then presented to the September 2024 Trust Board. And I'll leave it there, Chair, if that's okay. Thank you.
Wow, you did speak fast. That was great. Thank you very much. Super. Okay, colleagues, that's there in front of us. Richard Cramer. You're muted. You're muted.
I was going to say I'll speak fast too, and I failed at the first hurdle there, didn't I? I would just say that one thing that I think that EDI competency is important to look at it through the business of how we conduct ourselves as a board. And so I think it's an ongoing responsibility to ensure we're making the link between EDI and health outcomes, and we're making the links between EDI and the diverse needs of the workforce in all our agenda items, in addition to specific questions and items on the agenda. So in many respects, the work on EDI is ongoing. So another example, we have recruited USMA, but we're still going to continue to look for a diverse board as well. So it's just it's just ensuring these things are constantly on the agenda, and how we behave and conduct ourselves and look at things continuously.
Yeah, it's a really helpful point, Richard, and we do keep trying to improve the way we fill in our front sheet around EDI and the general benefits. And I think we miss a trick sometimes, because I think we could actually notice that we're doing more than sometimes we think we are, as well as knowing we've got to keep the foot on that pedal. So thank you. Could we then receive a note about annual board diversity report, approve that closure of 2 actions, and note that target dates are remaining 4, and that we will take the report in September. Isabel, then please, on the Remuneration and Appointments Committee.
Yes, thank you. This will be even quicker, I think, given that we don't go into detail of the items discussed within this committee for fairly obvious reasons in terms of the personal nature of some of the information. So, but just to say that in our recent meetings, we did receive an update on the progress around appointment of executive director and very senior manager appointments. And just to assure our public as well as our board that part of that is around the process and ensuring that we're minimising delays in recruitment, that we're appointing good partners to work with in recruitment. So there's a lot of work that goes on around making sure that we can attract and recruit the best and retain the best possible candidates we can. So we received an update on where we are with some of those appointments. And then the second item that just to bring to the board's attention is that we just received annual assurance in relation to the approvals that we make under our terms of reference. And part of that annual assurance also involves really robust financial governance and risk management process in place. So it's a strong and robust committee. Thank you.
Thank you, Isabel. Thank you for chairing that committee. Are there any questions for Isabel that she can answer? In which case we'll note the items that have been considered at its May 24 meeting, and come on to Aled. You've kindly been volunteered, but you were gracious in accepting. You're going to present the Charitable Funds Committee Assurance Report, please.
Thank you, Mary. So amidst comprehensive discussion of various charitable funds activities, there were 3 areas that we were seeking sort of greater assurance for. The first one was annual review of investment in terms of the kind of ethical and sustainability profile of the investment, and that's ongoing, and that'll be fed into the following meeting. So we were assured of that, and we will monitor that from here onwards. The other area was the spending plan reports for funds that are holding over £50,000, and we had partial assurance there in terms of one fund in particular, which is on the report. But then again, there's kind of plans looking ahead in terms of supporting fund managers to develop better spending plans effectively and how to spend money from those funds, because holding that level of fund has potential financial and reputational risk in terms of the charitable activities of the trust. So those two areas are ongoing and were discussed fully, and we will get further input from about those in the meeting next week, which is when we next meet. And then the third area is the family appeal, which is the fundraising appeal linked to building accommodation on the Trillis site for families of patients, of inpatients, where the original cost appraisal and evaluation was done 2 years ago. Since then, there's been significant changes, as we know, globally around building costs and construction related costs, as well as a change in one of the major donors that was expected to contribute towards the fund, and there have been some changes there, all of which have led the committee to seek further assurance around revised options appraisal given those changes, and that is also in hand. So, for example, there are various changes in terms of the increased cost and the changes in donation around the size of that build, down possibly to 12 rooms from the original 18, I believe, and the cost has escalated by around 1.2 million. So given all of that, the committee's request was, and our recommendation is for an updated options appraisal. And yeah, I'll leave it there, Murray. They were the three main areas of assurance we were looking for. Thank you.
Thank you. That's really helpful. And just to remind the board that we are considering this report in our role as trustees of the trustees of the corporate charity. I think that point around wanting to escalate to the trust board the need to develop an options appraisal for the appeal is important, and you pointed out the business of needing to do this in a timely way. So I think it's important we note that. I've got Ian and lots of other people, not all of whom I can see. Ian, Richard S, then Ella, then Alison, and then Adam.
Thank you. An excellent job, Aladin says, summarising the kind of key bits from our committee and charitable funds. So just for awareness, we'll be updating charitable funds next week, but we held our first fund advisor workshop with colleagues from across finance, procurement, estates and the charity team. We had a really good attendance at that and really good engaging conversations, and that was on the 12th of June. So I just, whilst we're talking about it, I think it's important just to share that with the wider board. The big piece of work, and Alison might touch on it as well, is the updated options appraisal, and there's been meetings with estates over the last few weeks on that, and we'll be bringing in a fuller update to the committee. And probably what we need to do at the committee is agree that I think it'd be useful for us next week when we meet as a committee to confirm what we think the timing of that will be, Mari. To that point of timing will be an important factor in this, and making sure we've got that sequencing right for it coming back to corporate trustee, having had that kind of full assurance through the appropriate subcommittee.
Ian, that's really helpful. Richard S.
Yeah, apologies. I don't need a detailed answer at this point. I should know the answer as a trustee anyway. But I think it's a really important piece of work to look at the ethical and sustainability investments. And I just wondered whether, as a charitable body, we already have a statement as to what we permit by those investments or not. As I say, I can see nods of heads, so I've got my answer. I don't need any more detail than that. But yeah, so I was just trying to work out the scope of that activity that was going on. Thank you.
Yeah, it's an important point though, Richard. Thank you. Yes, I'm nodding because I was part of developing it. Ella.
Mara, put my hand down because Ian covered my question. It was about timing.
Perfect. Thank you. Adam.
Thank you, Mary. My question has been covered already. Thank you.
Thank you. Alison?
Yes, Ian covered everything. Thank you.
Lovely. Thank you. Steve?
Yeah, thank you. I just wanted to get some clarity. So I think from what I've heard, the escalation to board is for information about work that's underway within the committee, rather than an escalation to the board for a kind of an action or an intervention. I understand that it's within the committee's remit to commission the options appraisal. I think Ian's updated on that. So I was just testing that we're it's to make sure that we're aware, which I think is important, rather than any outstanding action or other step.
Alison, do you want to come in there?
Yes, so quite right, Steve. We will do the work, working with estates, come back with a fewer options in terms of next steps for a place to stay, and then we'll come back to the board as corporate trustee with our recommendation on the way forward, and the bit that we've got to do between now and probably September is work out the actual timeline, but that needs more involvement from estates. Thank you.
Yeah, that's really helpful. Thank you.
That's really clear. Thank you, Alison. Really helpful. So on this report, we're being asked to note that report from the May meeting of the Charitable Funds Committee. And that brings me to you, Adam, the report from the Audit and Risk Assurance Committee, please.
Okay, thank you. And being deliberately brief, I think the report stands reasonably on its own, but to highlight a couple of things, please. The one item to flag to the board in a similar vein to previous discussions would be the lack of a system-wide assurance framework that would enable us to consider risk across the whole health system in Cornwall. And that is something that is yet to be developed. And again, we would be a key contributor to that. So that sits with us just as much as anybody else. But that's a piece of work that feels important that we should be taking forward as a system. And then just to tease out a couple of highlights from the report, we took full assurance from the work of colleagues in internal audit and external audit in terms of the work they've taken. They flag areas for us to improve in terms of our systems, our controls, our management of risks, our processes. An area we took less assurance on, so we flagged as partial assurance, is how we are making sure as a trust that we respond robustly to issues flagged by internal audit or external audit. So we flagged that as an area where we've taken partial assurance, and there's work underway to improve our timeliness and robustness of response to external audit or internal audit recommendations. Since this report, which was from the May Audit Committee, we've had a special audit committee which finalised the annual report, the annual governance statement of accounts that have all been signed off, audited appropriately, and will come to our annual public meeting in September. And I will probably stop there, Chair.
Thank you, Adam. Thank you very much. Note the point about the internal audit report. And again, with the lack of a system assurance framework, I think those are matters which Steve and I, they're ongoing discussions, and I know the senior executive group has that, that knows that, but that point is noted by the board. Other questions for Adam on that committee? No, Adam, it looks like you've done a good job. Alison.
I hope this is acceptable. Just wanted to share some hot off the press good news that the HR systems transformation programme has received significant insurance in the latest audit. So I couldn't be more delighted, and just wanted to say thank you to the team.
That is lovely news. Thank you for sharing. Thank you, Alison. Well done. Okay, let's know this report, please, and move on to the Board Assurance Framework report, inviting Lindsay, please, to introduce your report.
Thank you, Chair. Presented is the Board Assurance Framework. Board colleagues will be aware, but just recap for public knowledge, is that the updates to each element of the BAF are made after each assurance committee meeting and or during a meeting with the executive lead, which happens on a monthly basis. They're made in track changes for ease and transparency. The board approves the Board Assurance Framework, and it lasted this in May 2024. A couple of things to note for board members' information is that the board had an initial discussion regarding considering the organisational risk appetite, and a working group has been established, and there's a meeting later this month ahead of another full board discussion, and at that time obviously the BAF will be updated to reflect any changes to the organisational risk appetite. I also wanted to highlight to the board that the BAF elements will be updated to reflect the Year 2 priorities, and we will ensure that going forward the predicted scores are considered and implemented in a timely way, and as steward of the BAF I'm sure that these improvements are made to future BAF iterations. The report clearly outlines the changes that have been made in the BAF elements as track changes, as well as outlined in the report. So I don't intend to go into too much detail, but would draw people's attention to the resolutions as set out in the report, which highlights the recommended closure of several BAF elements. Several gaps in assurance relating to the BAF elements. I'm happy to take any questions, Chair. Thank you.
Comprehensive report, really helpful. Colleagues, do you have any questions? Robin?
As an observation, I read these all the time, and I read it over last night again and thought, actually, I've missed a trick. So I'm going to link up with Lindsay, and we'll make sure that in BAF 2, the workforce piece, where we've been doing so much work on the violence prevention reduction piece, that probably is part of our mitigation for some of our gaps and controls that are on the BAF itself. So we'll tie that together, and colleagues will see that in the next iteration through the normal process.
Thank you. Thank you very much. Others? Comments? Isabel?
Yeah, I just wanted to, I suppose, state the obvious that we are in many respects operating outside our acceptable risk tolerance levels that we debated as a board fairly recently in our development session. So I think it's just worth noting that, whilst there's very little that we can do to mitigate overall, I think we do have to acknowledge that that we're operating in a really challenging environment, and that we are maintaining a huge amount of risk, which I do think that the sooner we can get a shared risk system running across the system, that will help us.
Yeah, because a lot of the risks are dependencies, aren't they? Ella?
Yeah, I completely agree with that, and the BAF 3 as well, we're pushing for that system assurance framework as well, which I think speaks to the point earlier around how do we as a whole system, and that includes us, optimise our ability to really make the changes we need to see and want to see in our services. But I was also just going to say on that point, we have just started the new process. I can't believe I'm saying this, having just finished the planning round for this year. We're starting the planning round for next year, which is a really positive thing. We're doing it nice and early with system colleagues. And as part of that, we have just agreed that we're going to our very first workshop next week. Each organisation bring their top risks for consideration by each other by way of scene setting for that. So I think that just it's not a risk assurance framework yet, but it's the kind of maybe the start of us working more collaboratively on that and making sure we're planning around our key risks and around our key issues.
That's really helpful, Ella. Good to hear that. Thank you. Kim?
So Ella, if we can touch base with Aoife and myself as well, because we've got a perfect example with our current internal risk summit as regards absolutely remapping, and that will fit into a wider, whilst we do our internal part of our ED overcrowding risk, that's a great example to take to the system to get that, this is what we can take internally, this is the support we need externally. So really keen to have to catch up on that one.
Great, thanks, Kim.
Thank you very much. So, board, if you'll forgive me, I'm not going to read all this out because my voice is beginning to give up. But you do have all the recommendations and noting and approvals in front of you on the report. So if you'd be kind enough to make those approvals, that would be helpful to me. Aoife, welcome. Very nice to see you. Thank you for joining us. You're going to introduce our corporate risk register.
That's correct. Thank you, Chair. Good afternoon, and thank you for the invitation to the board. This risk register was presented to our Audit Risk Assurance Committee in May and is here for information today. There was just one thing that I wanted to flag to the board for information, and it may have been touched on already, so apologies if so. As Kim has just mentioned, risk 9048 is in relation to overcrowding in our emergency department, and the risk was presented to our executive risk group last month, and an outcome of that was to hold an internal risk summit, as Kim has referenced, which took place yesterday with key executives and lead clinicians around the table. A number of actions were identified as a result of that at that summit, which we will be taking forward. And as Kim rightly says, will feed into that system piece of work, which I would welcome. I know that the board is cited on the Trust Flow Improvement Programme and indeed actions across the wider system in terms of mitigating this risk, and we'll provide further information on the outcomes of those conversations in our next corporate risk register. So taking the report as read, I'm happy to take any questions or comments.
Thank you, Aoife. Nice to hear that. Are there comments or questions? You've done too good a job on the report, I think. Okay. In which case we are asked to receive and note that register, corporate risk register. If we could do that, thank you, Aoife. The following two items are starred items. I haven't been notified of any questions on those, so I'm going to suggest that we note the publication of the Trust Register of Interest for the Trust Board and other decision-making staff, and that at 15 we note the decision taken via e-governance in May to approve the People and Culture Committee terms of reference. Oh, and my system has just closed itself down. I'm not quite sure why. Lindsay, the next item on the agenda is 16, and it's the consideration of risk we've had this time, I think.
That's right, Mary. Yeah, sorry about that. Yes, consideration of risk. So very happy for other board colleagues, particularly my executive colleagues, to comment also. But just touching on what Aoife was just saying around the updates from the internal discussions around the UEC and the overcrowding in ED, we'll reflect that appropriately on the board assurance framework, following changes to the corporate risk register. We've talked a lot today around quality versus finance. We've talked a lot around system architecture and governance mechanisms, and particularly around the system assurance framework. And just to give some reassurance that I have meetings scheduled with my company secretary colleagues and our risk leads with regards to developing that system assurance framework, but we'll make sure that that's accurately reflected in the board assurance framework. We talked about industrial action, and there was an action from the last board around including that back onto the BAF, and Ian, as Chief Finance Officer, and I have done that, and that's now included. And lastly, we talked a lot around workforce and the need for a medium-term workforce plan and how that links with and triangulates with our finance and our clinical model. So I think there should be some further consideration as we are looking at the board assurance framework with regards to these matters that we've discussed. Thank you.
Has anybody noticed anything else? Alison?
Yeah, just on that final point, we do have a workforce plan. What was escalated was the lack of a system workforce plan. So I just want to make that distinction, and if the wording could be updated around that, that would be helpful. Thank you.
That's noted, Alison. Thank you very much. Any other thoughts? No, in that case, let's go with that. Bringing us to item 17, a bit late, I apologise. Questions from the public. Lindsay, Company Secretary, Have we any questions from members of the public today?
Thank you, Chair. We haven't had any questions from members of the public today. No questions were received during the live streaming of this meeting, nor ahead of the meeting. However, we did have one comment from Becky Cooper, who has said, we have had the pleasure of the volunteering team helping to obtain patient feedback for national audits. The support has been fantastic. Thank you, volunteers. So that's a lovely comment that we've received. Thank you.
Really, really nice. Thank you for sharing that. And very unusual for us not to receive questions from the public. Maybe they're all out voting or something like that. Okay, so how have we done today? What's worked well? What might we have done better? Have we been consistent with our board etiquette? Have we contributed to patient safety? Have we considered health inequalities? And are there matters to communicate to system partners? Alison?
I was just going to sort of play back one of the key metrics in inequality on the NHS providers' new maturity framework is, does the board reflect on equality matters? And, you know, I really think we are growing on that, because I'm hearing it being streamed within conversations and not just about the front template now.
That's a really interesting reflection, isn't it? Thank you. We're all stunned. Okay, so I think we have done reasonably well. I think those of us, like me now included, who are working through a fog of COVID, have done very well being here. So thank you for that. It is now about 2 o'clock or something like that. We're due to start again at 2:30. Are colleagues happy with taking half an hour, or would you like to take less time? What's half an hour? I'm getting nods on the half an hour. Okay, yes, great. Please. Let's reconvene at 2:30. The date of the next meeting is the 5th of September for board in public, and we will now take a break until 2:30 when we'll reconvene for our board in private. Thank you very much, everybody. See you later.